Nice. Kia ora, morena, haere everyone, to the third and final day of the PHONZ conference. By far the most important day, I reckon, personally biased there. We'll start off with karakia. Karakia tātou, whakataka te hao ki te uru, whakataka te hao ki te tonga, kia mā kina kia utu, kia mā tara kia tai, ehi aki ana te atakura, he tiho hi hoka, he hehu te he Māori ora. Kia ora. Well, today we've got a number of speakers, and our first speaker is Professor Neil Pearce. Right, before I get into that, sorry, I shall mention the Mentimeter, which you'll see a slide come up throughout the day. Looks like this. Thanks, Patrick. And if you can just log in, go to this website, or take a photo and click the link that comes up using that picture there, and then type in that code, and then you'll be able to answer some questions that we will ask. Is it the same question, Patrick, or is it different questions throughout the day?
Today's question is on, well, the theme of the day, which is public health communications. From memory, the question is something along the lines of, what is the most important quality of good public health communication, or words to that effect? So it'll be interesting to see the audience's thoughts.
Yes, very good question, very deep question for a Friday morning.
Have they had their coffee?
Nice, thank you, Patrick. So I will give you some gentle reminders throughout the day. So our first speaker is Professor Neil Pearce. Professor Pearce is a professor at the London School of Hygiene and Tropical Medicine. He's been there since 2011. And then before this, had been working in New Zealand for a number of years. And his career has focused on epi and biostats methods and their application to studies of non-communicable diseases, occupational health, and environmental health. Neil is a fellow of the Royal Society of New Zealand and the Academy of Medical Sciences, and is past president of the International Epidemiological Association. So with that, I think it's a pre-recorded session, isn't it, Patrick?
It is. Stand by a moment.
Push play.
And that should be playing.
Hi, so thanks for inviting me to speak at this conference. I'm very sorry that I can't do it live, but at the time that you're watching this, it'll be about 10 p.m. and I'll be on a train arriving in Glasgow. So it seemed better to record it rather than try and do it live. What I'm going to talk about is why we need to keep doing surveillance using population surveys. And what I'll do is I'll give several examples, and then using these examples, I'll talk about why electronic health records and global burden of disease estimates are good, but they're not enough. We have to supplement with population surveys, and then I'll draw a few conclusions. So the examples I'll talk about are COVID-19, and then asthma, and then chronic kidney disease of unknown cause, CKDU. So with COVID-19, this is where we were 3¼ years ago. This is actually the last figure that I downloaded to my computer and stuck on my wall at my last day at work, and it was still there on my wall about 1¼ year when I came back. And you can see that the rates were very high in Italy, but in the UK it was just getting started. But at that time all we had was cases, and there were a number of problems with the data. And I wrote an editorial for the American Journal of Public Health with Jan van den Broek, Tyler van der Wiel and Sander Greenland on the need for accurate statistics on COVID-19 and how these were essential for policy guidance and decisions. So for COVID-19, we start with a population, and then some of that population at any one time is infected. And then a subgroup of the population has symptoms, but that includes people who are infected with COVID and people who were infected with other respiratory viruses which cause very similar symptoms. And then some of those people get tested, and at the time, with a few exceptions, people were only getting tested if they had symptoms. So these are the test positives, the false negatives, the true negatives, and the false positives. And then some of those die. So we've got quite a complicated situation because none of these squares really line up. So we know how many deaths are test positive. We sort of know the cases, but of course there were many cases in people who didn't have symptoms. Then we know when people were getting symptoms, and we know the total population. But what we don't know is the total number in the population that has been infected at any one time. And this was actually crucial because we needed that to work out the infection fatality rate. And if you can think back 3 years or more, there was huge argument about whether about what this was. The best estimate was about 1%, and I think it in the end turned out to be about that or a little bit less. But the policy implications were quite different depending on whether the infection fatality rate was 1 or 2% or whether it was maybe 1 in 1,000. So if it was 10% and you can eliminate the disease, of course you'd do it. If it's 1 in 1,000, then you might think differently. So the key thing we didn't know at the time was what proportion of the population has been infected. You know, what numbers of people are producing these cases that we see. Now, the UK actually responded quite fast, even though it took a couple of months. That was very fast in the circumstances. So they set up this survey called the COVID Infection Survey, which I'm a member of. I got £25 every month for taking a swab and answering a short questionnaire. So it was very expensive. It involved, I think, 150,000 people, something like that. But it worked very well. And that was unusual. Most countries didn't have surveys like that, either because they didn't think of it or because they just couldn't set up a survey that fast. So there's a long-term need for routine disease surveillance systems, and we need to ensure that they're in place not only for known diseases, but that they're ready to be activated when new diseases such as COVID-19 come along. And disease surveillance and descriptive epidemiology will continue to be the essential foundation for good epidemiology and good public health. Second example was asthma. In most parts of the world, the problem is that most children who have asthma has not been diagnosed, and often a child needs to go to the GP quite a few times until they're diagnosed with asthma. So, for example, I think it's a bit better now, but when we started the ISAC study, which I'm about to talk about, back in 1990, there was evidence that the average child in the UK would go to the GP 10 times with symptoms before they were willing to diagnose them as having asthma, because it's a hard diagnosis to make, and there was a stigma attached to having asthma. So of course the rich children keep going back and the poor children don't, and you actually had a situation where there was almost no social class difference in asthma prevalence. If anything, it was a bit more common in poor people, but diagnosed asthma was much more common in rich families. So, and this was true all over the world. So the only way to estimate population prevalence and look at differences between countries and regions and changes over time is to do repeated population surveys, which is what we set up, Ines Asher and me and a few other people, with the International Study of Asthma and Allergies in Childhood. So the first survey was done in the 90s. We published the protocol in 1990, I think. And we had 155 centres in about 60 or 70 countries, I think. About 500,000 children took part in the initial survey. And this is the world's first asthma prevalence map. Now, I published in The Lancet in 1998. Now, I could talk about this at length, but I'm just going to mention one feature relevant to New Zealand, which shows why these sorts of comparisons are important. When we set up this study, the dogma was that New Zealand had the highest asthma prevalence in the world. The reasoning for that was that we had the highest death rate in the world, but we had the highest death rate because of a drug called phenoterol, and when that was restricted, the death rate fell by 2/3 and has been very low ever since. We did have high asthma prevalence, but nothing unique. It was equally high in Australia, the UK, the US, Canada. So at the time, people were saying we have the highest asthma prevalence in the world. What could be causing it? We have a lot of cats, we have a lot of carpets, we live by the sea, there's a lot of salt. And it was all completely misguided, because anything that was unique to New Zealand could not have been the explanation. Instead, we had to ask, what does New Zealand have in common with countries like Australia, UK, US, and Canada? But it was only through doing this survey that we found this out. This is ISAC phase 3. There were about 300 centres in about 100 countries. And this is the slide I just showed you of the phase 1 results. And this is the change from phase 1 to phase 3. And blue means prevalence has dropped a bit. Red means it has increased, and white means virtually no change. And what we actually see is that we don't know when asthma prevalence started increasing, but it was sometime after the Second World War, and it was probably at its peak for countries like New Zealand in the 1990s when we did the first ISAC survey. But 10 or more years later, it had fallen a bit. So it reached a peak in the 90s and plateaued and then dropped, whereas some other countries are increasing to catch up. We still don't know the meaning for this or the reasons for this, but it's clearly very important in trying to understand what's happening in asthma globally. So the Global Asthma Network is, ISAC has become the Global Asthma Network. So that's carrying on the work of ISAC, and we're doing repeated surveys. We published some new ones recently, and every 4 years or so we publish the Global Asthma Report, and the last one came out just last year. But the core of this is the ISAC data, and we do surveys about once every 10 years. The third example is chronic kidney disease of unknown cause, which you may not have heard of, but CKD is normally caused by diabetes or hypertension. But there are epidemics of chronic kidney disease not associated with these risk factors, affecting young people in rural communities in Central America and South Asia. So this has been termed CKDU, chronic kidney disease of unknown cause. Now, we know that this is common in Central America and South Asia, South India and Sri Lanka, and there's anecdotal reports in other tropical regions of the world, like Egypt. There's lots of rumours that the workers at the World Cup in Qatar were getting CKDU, but there's no good evidence, and it's not clear if the disease exists outside of Central America and South Asia, or even if it's the same thing in those two places. So in Sri Lanka, at last count, 37 hypotheses had been suggested for the possible causes. No one still really knows. The main factors we're looking at are pesticides, heat stress, heavy metal in the water, and infections. But just to give you an example of how difficult these things can be, is quite a few people have suggested that pesticides might be a cause of the epidemic in Sri Lanka, and with not very little evidence for it. It's just speculation. But partly as a result of this, the Sri Lankan government banned some of the major pesticides a few years ago, and within a year they were having to import about 1/3 of their rice. But because of various problems with the government, they ran out of foreign exchange and the government collapsed, and Sri Lanka had about a year of chaos, and it's only just emerging from this. So all that came in part from false speculation about what may be causing CKDU in Sri Lanka. So we've set up something called DEGREE. I'm not quite sure how you get the acronym DEGREE out of this, but we managed to. And it's similar to ISAC, but it's doing prevalence surveys of CKDU in different countries. I should stress that you can't pick up CKDU in regular health records, because for a start, in most parts of the world, you can't pick up CKD. You can't pick up chronic kidney disease in general, because a lot hasn't been diagnosed. But also, to find CKDU, you've then got to exclude the cases of CKD that also have diabetes or hypertension. And that's virtually impossible to do with sufficient accuracy, even in countries like New Zealand or the United Kingdom. So you have to do population surveys. We're just analysing the first round of degree data now, but these are some preliminary results from just a few countries. So these are 5 centres in Sri Lanka. This one was chosen to be low. Anything sort of 2% or less is low, and anything 5% or more is high. So it's clearly in Sri Lanka. In India, it's in rural South India, but not in the other parts of India that have been looked at. Nicaragua, it's well established. It's one of the places the disease was first documented. But then we went to Malawi and Peru and did surveys and found nothing, even though they're hot, they use a lot of pesticides and so on. So already, just by surveying a few countries, this is casting doubt on some of the existing hypotheses and perhaps suggesting some new ones. These photos I took myself in India, and they illustrate the problem. So this is looking south on the highway on the east coast of India, up near the border with Orissa state. And one side of the highway, about half a kilometre or a kilometre away, there's this village where they mostly grow coconuts, so they work in the shade. They don't use many pesticides. They have plenty of water. On the other side of the highway, so these two villages are only about 1 or 2 kilometres apart. Here they grow rice, they work in the sun, they use a lot of pesticides. So which village do you think is being decimated by CKDU? It's this one, the one that doesn't have the recognised risk factors. So it shows how these sort of population surveys can really suggest that the current dogma is wrong and give ideas for new risk factors. One possibility here is that there is arsenic and silica in the water because they dug deep wells. So that might be an explanation, but we're still looking into that. Certainly it doesn't fit with the idea of heat or pesticides being the main cause. So why can't we just do these sorts of analyses with electronic health records and global burden of disease analyses? Well, firstly, new problems can't be detected using electronic health records. When something like COVID-19 comes along, it doesn't even have an ICD code, but also, as we know, you just don't pick up cases initially, and you certainly don't pick up the number of infections. So you have to go out and do surveys. Also, many old problems like asthma also cannot be detected accurately using electronic health records. The global burden of disease estimates rely heavily on population surveys for some of these outcomes. You know, if you're looking for cancer incidence or mortality, then in at least some parts of the world you can get that from official records, but asthma, you've got to go and do surveys. So the global burden of disease estimates for asthma almost all come from ISAC, and I supplied them. I was on the committee. We also supplied some adult data from the European Community Respiratory Health Survey, and for adults there was a few other surveys that were relevant. For children, ISAC already covered 100 countries, and there was just nothing else that actually added to what ISAC had already done. So these global burden of disease estimates rely on people continuing to do surveys. But also, the GBD estimates are probably reasonably valid on a global scale, but they're almost useless in terms of identifying differences between countries and changes over time. Firstly, talking about differences between countries, the problem is the GBD only has estimates on some countries and not on others. So if you think of the CKDU example, you can, and that photo I showed of the two villages, you can't extrapolate from one village to the other, and they're only 2 kilometres apart. You can't extrapolate from South India, where CKDU is a problem, to North India, where it looks like it's not a problem. So if you have, if you're looking at CKD or CKDU and you have data on some countries and not on others, the GBD will come up with an estimate, but it's almost completely useless because it can't identify whether that particular epidemic is occurring in those countries or not. And the same thing applies to changes over time. For example, The original GBD estimates for the number of people in the world who have asthma come from the data I supplied. And the initial estimate was 343 million people. Now, Bill Gates likes up-to-date data apparently, so the GBD are doing annual updates. And when they do these, the number of people in the world with asthma goes up 50 million one year and down again the next year, and then down 30 million and back up again. And in that time, we've collected no new data. Isaac and Gann only get done every 10 years or so. So how do they get these new estimates? Well, they have this very big sophisticated Bayesian model, and they plug in the data they do have and run the model and essentially impute all the missing values for the data they don't have. Now, from year to year, they have almost no new prevalence data. What they do have is things like asthma death rates or asthma hospital admissions in countries in North America and Europe and Australasia. And if they go up a bit and they run the model, it predicts that everything has gone up a bit. So prevalence has increased because it must have, because that's correlated with the death rate. And of course, it's complete rubbish. So the GBD is good on a global scale. It's been good to identify that NCDs are very important globally, for example. But when you're looking at things that are changing over time, or things that vary from country to country, like special problems like CKDU, it's useless, and I wouldn't rely on the findings at all. So in conclusion, there's some diseases like cancer where prevalence and incidence can be estimated from registry data and electronic health records, at least in most Western countries. For many other diseases, even in Western countries, you need to do population surveys. And this applies to new diseases like COVID-19, but also for many old diseases like asthma. And electronic health records and global burden of disease estimates cannot fill this gap and never will. You need to keep doing population surveys as a complement to what we can learn from electronic health records and GBD estimates. And therefore, we need to maintain the ability to rapidly establish population surveys when new diseases arise. So when COVID-19 came along, the UK was able to establish a survey very quickly, but most countries weren't. They weren't able to. They didn't have the capacity. How do you maintain the capacity? Well, the best thing is just to be doing regular population surveys anyway, particularly focusing on things like asthma and diabetes and so on, which you can't completely pick up with electronic health records. Doesn't mean we have to be doing them all the time, but we have to be doing things like national health surveys every 5 years or so, and occasional special surveys in between, so we maintain the capacity, both the staff and the facilities and the intellectual capacity to do these population surveys very fast when the next pandemic comes along. So thanks very much.
Nice. That was a wonderful presentation from Neil, and we thank him for contributing. Like he said, he was on a train heading towards Glasgow, but Neil has said to us that we can get to him any questions. So if you have any questions, feel free to use the Q&A or the chat function, and we'll take note of those questions and get Neil's reply, and then we'll put them on our website. Just a friendly reminder around the Mentimeter. If Patrick can bring up the Mentimeter slide, and then so join mentimeter.com, use that unique code up the top of that slide, and then you can answer this question. Also, feel free to use the reactions button to express your appreciation of our speakers, which is a nice segue into our next speaker, which is Michael Baker. And I see you're online there, Michael. Michael became a household name during the pandemic for his work related to COVID-19 in the response. Michael was a professor in the Department of Public Health at University of Otago at the Wellington campus, currently on a sabbatical as a visiting fellow at the Norwegian Centre for Advanced Study, and is joining us from, is it Cambridge, Michael, or London? And Michael's interest includes infectious disease, environmental health, and improving housing. And as a fellow student of Michael's, I can attest to his enthusiasm and passion for all things public health. So with that, Michael, I invite you to the floor and you may start your presentation.
Yeah, well, kia ora, everyone, and thanks, Tim, for the introduction. Thanks, Barry, and the rest of the team from PHONZ for organising this really remarkable lineup of speakers spread across 3 days. So yes, I'm sitting in the Churchill residence in Cambridge, and it's quite a different environment from the one I'm used to, but very, very hospitable. So today I'm going to talk about very much in the communication theme, and I'll just share my screen and presentation. Just a moment. So hopefully you've got the full screen there. So
that looks good.
Why does public health communication matter? I don't think I need to really, in many ways, ask this question for this particular group, but I will spend the next few minutes talking about this. So what I want to do is talk about the role of the new Public Health Communication Centre, which has just started this year, and then 3 or 4 reasons why I think communication matters. And we often think, yes, informing the public on health issues, building trust in science, and ultimately providing some protection from disinformation. But I think, for me, the big area is around evidence-informed policy, and that, for all researchers, is this translational obligation I think we have. And I think in public health, people always get this, that, you know, your work doesn't finish when you publish something. You've got to really be concerned about the policy implications. And the other area which I've grown much more concerned about is government decision-making processes and the whole area of strengthening transparency and democracy. And people, you know, they have the kind of throwaway line, the causes of the causes, but once you've been, and I think most of us have this experience after a while, you think everyone agrees that something should happen, but it doesn't happen over many years. And you think, well, what is it? What are those common factors that are holding us back? So talking about initially the new communication centre, I'm just going to briefly talk about its purpose and rationale, what it is and what it does. So this was basically supported by an endowment from the Gamma Foundation, who support a number of activities in tertiary institutes across New Zealand, and also the Critic and Conscience of Society Award. And I think they're very publicly minded couple who support these activities, and they've given us a generous endowment to sustain this centre in perpetuity. And so its purpose is to promote policy, practice and public awareness to protect and improve the health, well-being and equity of the people of Aotearoa, and also the environment in which we live. So again, I think it would be a very common values for many of us in public health. So we know that this country has a wealth of public health expertise and research. The pandemic, I think, showed, it really highlighted the value of having independent expert commentary. But we have many challenges, and I would say there's probably a lot of agreement now that we need transformational change. It's not a matter of just iterative change in major areas like climate change and equity. So we know also, unfortunately, the pool of independent voices is possibly shrinking. There's limitations on NGOs, and in a way, the voice of regional public health is maybe a little bit more precarious now in terms of the institutional arrangements and the constraints on some of the independent voices we've had in the past. We also know, and I think this is another realization you have, that public health research competes with very well-resourced commercial and ideological interest groups that are not necessarily aligned and maybe actually quite antagonistic to public health. So the other thing that is really stuck in my mind, this would be my single biggest take home from the pandemic, is that we basically need evidence-informed strategy. And we've seen the huge benefits in New Zealand from having that. And this is this fusion of effective science and good political leadership. And one without the other is very frustrating, as we've seen around the world. So the centre has, at the moment, 3 very part-time directors. It has some full-time staff who are, I think, have been great at getting the centre going, really outstanding people, and some affiliated researchers. So by communications group standards, it's a very small group, very small amount of resources, but in public health, we're used to doing, I think, a lot with very little. We've got really an outstanding advisory board, which covers the domains of public health and also the media sector. And I think it's drawing on some of the really great principles that the Science Media Centre has established by its founder, Peter Griffin, and Daisha Herbelock, who now runs it very effectively. So what do we do? Well, it comes down to a very small number of things. We have a regular online publication, the Public Health Expert Briefing, which took over from the Public Health Expert blog, which has been going for a decade. And one of the things we're really devoted to doing is highlighting important research and evidence that's particularly come from New Zealand, but using other media as well. I mean, there's a lot of choices like op-eds and the conversation and so on. And also we want to have a very good network with the public health research community, journalists and policy professionals. So one of the things that's I think is interesting when you pause to reflect, I mean, what is communication about? What are your channels? Who produces the content? How do we deliver it? And who do we want to reach? And a lot of the time people think, oh, well, we want to reach the public. The public is, as you know, very segmented. There is no way of reaching the public as a whole, but you can reach certain portions of them, often via the media. You've got health and public health professionals and practitioners you want to meet or reach. And then policymakers are often the key audience. And sometimes there's only a very small group of policymakers. Sometimes it may be an N of one, maybe a single minister that you really want to influence. So when we look at informing the public and providing some protection from disinformation, what does this involve? And I think part of it is about knowledge. It's not just imparting knowledge, but it's also building up a trusted relationship, and I guess improving the trust in science. And you can see this, I mean, people sometimes talk about inoculating against disinformation. And part of that is giving people the ability to make scientific judgments, which is really a shorthand for saying using evidence. And we have to think about what the impact of disinformation is. And I think issues around protecting the messenger. If some of you have been messengers, you know that it can be quite a shock. So we know at I think a fairly logical level from first principles, and this is really, if you look at during a pandemic response, it's obviously critical to be able to communicate. You have to inform and motivate essential behavioural changes by individuals and organisations. And one of the things, of course, about pandemics that's very distinct is that the behaviour of individuals affects population risk. And that does not apply to all hazards. Often you're changing the behaviour of individuals to affect their own personal risk. This is where we are interconnected, and again, why the government has a huge interest in collective decision-making. Ultimately, you want to build trust in collective action and the social licence. That's the permission the government has to act. So one of the, we're always looking for evidence about whether trust in government makes a difference. I mean, intuitively, we think it would, but here is some evidence that's just come out very recently. And this is looking at the relationship between the Global Health Security Index, which is a tool for grading the capacity of countries to manage pandemic threats. And then you've got a regression of that against the excess COVID-19 mortality. And this is showing that there is a significant inverse relationship, which suggests that grading countries on their capacity actually means something. And the part of this that's really interesting, sorry, it's a very dense slide, and this is even denser. This is showing that there are 6 components to this index. And the component that had the greatest or the strongest relationship with your actual outcome in terms of excess mortality was the risk environment category, which includes government effectiveness, public trust in government, and inequities and social exclusion. So this is basically saying that countries like New Zealand that I think have worked very hard on these dimensions it has been important. This is showing that it actually does make a difference when you're looking at outcomes. So that's a piece of quite strong evidence, I think, from the pandemic. So when we look at the area of disinformation and misinformation, I think everyone is probably very familiar with the distinction. False information is a fact of life. We make mistakes, we have errors. But disinformation is when it's got an intentional element, this idea of manipulating narrative or facts. It's propaganda. And I do remember this sign really bugged me. It always seemed to be in camera during the occupation. Natural immunity, 99.6% effective. And obviously the person who wrote that sign wasn't reading the New England Journal of Medicine, which said at the time that it was more like 56% effective against the Omicron variant. But that's the kind of misinformation that comes out in various ways. So this for me was a high point of disinformation. This was a remarkable scene when these women were interviewed and they said, we have to leave the occupation because basically we've run out of aluminium foil from the local supermarket, we've stripped the shelves. And seemingly they were not joking. They really believed that their lives were endangered by electromagnetic radiation being sent out or beamed out from the beehive to influence them. And there's also, I think, quite a tragic scene on Counterspin when Liz Gunn was clearly suffering, and it turned out to be with COVID, and couldn't get through the interview. So we know that from work done on disinformation in New Zealand, that many people self-report that they are exposed to disinformation, and they do believe it's affecting the views of themselves and people around them. So one of the things to say, well, does it matter? And this is a framework that I still find quite useful. It's a model that's been around for a long time. And this is a cognitive framework for looking at the health beliefs model, which looks at what factors contribute to whether people take health protecting behavior. And this is things like, am I susceptible? Is it severe, a severe threat? Are there benefits from the intervention like vaccination? Are there barriers? Am I seeing regular reminders? And do I feel confident that I could carry out this behavior? So I think this still stands quite well, this framework for looking at whether people take action like vaccination. So again, this is a very dense slide, but the point I'm making is that misinformation, disinformation systematically erode all of these components of the health beliefs model. And you can see why. I mean, saying that the pandemic is fake, vaccination is dangerous, there's so much uncertainty, you should wait, and so on. And that's one reason why I think disinformation only has to really erode one of these key elements, and that will interfere with the decision to get vaccinated. So it's showing the kind of scale of issues that we need to manage. And this is one of the consequences of disinformation. Has really magnified what I think was already some degree of uncertainty from some people about vaccination, childhood vaccination. We've seen that rates decline in many countries, including New Zealand, and unfortunately a widening inequalities with vaccination coverage dropping faster for Māori and Pacifica children. So I think that's a very unfortunate consequence of disinformation. So how do you respond to disinformation? Well, one of the areas that comes up a bit is fact-checking. Generally, we don't want to do it very much, or we may fact-check very egregious claims in mainstream media, but online, generally, it's best avoided. But I did get drawn into commenting on information that was put out by Naz, who's a well-known influencer and epidemiologist, it seems, that she got COVID-19. She's had normal flus, which have been 100 times worse than this one, and therefore no one should worry about it. And obviously this is a serious error of thinking to generalize from your own experience to the entire world. And so it was irresistible to respond to that. But generally, it's something you need to do very cautiously. So where does disinformation come from? Well, multiple sources, and we've seen some quite fringe political parties in New Zealand take advantage of disinformation, war on 5G towers, on fluoride, and a whole lot of other things. And fortunately, they get very little support. We see some mainstream media internationally, like Fox News, exploiting this. We've also seen scientists in the Great Barrington Declaration internationally pick up on this with a lot of financial backing. And we saw briefly COVID Plan B in New Zealand. So there's a lot of sources. And also there are a lot of very malign actors internationally who are funding this disinformation. So how do you challenge this? Well, I think disinformation is still very difficult. This is a summer school we ran at the start of the year looking at disinformation. I want to really congratulate John Kerr from our centre, who I think has a very good understanding of the challenges of looking at disinformation. And there's some of the people I'm meeting in Cambridge at the moment who are really, I think, thinking very hard about this challenge. So one of the things I just have to say a little bit about is the experience of being a messenger and how confronting it can be at times. I mean, anyone who's talked about COVID or become a COVID commentator, suddenly you get truly remarkable emails you've never seen in your life before, because you're used to, I think in public health, you say things that most people would regard as very reasonable. You may be ignored, but you know, generally people have quite a benign view about what you're saying. But here, the intensity of vitriol is like nothing I've ever seen before. But some of it took a weird twist. I woke up one morning and suddenly my physog was on posters around the country along with a few other people. And my kids loved this, seeing Dad on a big billboard. They thought that was hilarious. They thought, surely there must have been some crime. But my crime was saying traffic light system was only designed to nudge people towards vaccination. Hardly the worst thing I've ever said in my life. But anyway, that statement obviously antagonized Voices for Freedom. And up here, we had a team of 5 million, but some of us became the team of 5 tyrants. And of course, the ultimate accolade, Cam Slater, that particularly horrible right-wing blogger, singled me out for some comment. So one of the things I found also remarkable was having a fake account set up in my name. It looked like me, it had my name and my photo, but if you look more closely, it was actually Michael Faker. And this person was so determined, they put out an average of 12 tweets a day for a year, basically saying the kind of things I would say, but not quite right, and also including some very undesirable comments, and some of it to get retweeted, and it took a lot of effort to get this taken down. So what do we do in terms of advocating for better policies? We've got science-based advocacy, agenda setting, evidence translation, and so on. So I'm just going to run through these things quite quickly. Obviously, one of the big bits of science advocacy, I think, in New Zealand was around switching from mitigation approach to the pandemic to elimination. And that I think, has proven to be a very good choice for New Zealand. We saw the government on the 23rd of March announced essentially an elimination strategy, that everyone would go home and have a circuit breaker kind of lockdown, a stay-at-home lockdown to basically eliminate the virus from New Zealand. And this was, with only 100 cases and no deaths, was seen as a very vigorous response at the time. So 3.5 years later, if we look at, I think, one of the best indicators, excess mortality, New Zealand is still at 0 excess mortality after 3.5 years. And I think arguably one of the most effective responses of any country. So we put out the briefing now, usually 1 or 2 issues a week. highlighting New Zealand research, putting international research in context, and commenting on emerging issues. And these are examples of some of the topics we've covered recently, looking at the impact of the cyclone and where it fitted in the scale of sudden mass fatality events, looking at other emerging diseases and the kind of responses that we think are appropriate. And again, I think this was one of our articles we were very pleased to see had a very high readership around looking at inequity in New Zealand, and I think it was very well written in terms of why this really does matter for New Zealand. And a lot of work looking at nitrate contamination in the environment, and really leading to a lot more work in that area. We also analyse media coverage, which is very helpful for seeing what kind of issues get real traction in New Zealand. And one of the other things we do, of course, beyond the briefing, is we do a lot of promotion of these ideas through other media, for policy submissions, and a lot of networking with policy professionals and so on. So how can we improve decision-making processes in New Zealand? And this is really moving beyond the exact individual decisions to how we tackle big challenges in New Zealand. And it's really looking at picking up some of the important global health agendas, looking at particularly the commercial determinants of health, and greater transparency and controls and lobbying. And a really strong theme that we're concerned about is this shift to long-term thinking. And I think if you really embrace this, it does change everything about how you make decisions. So one of the, I think still a very useful basis for looking at the global health agenda is the other sustainable development goals. And not all of the ones are, I think that some of the most important ones are not specifically about health. This, for example, goal number 16 is around building effective, accountable, and inclusive institutions at all levels. And I think that really is a profound shift that will drive many other health advances. So at the moment, there's obviously, I think, very justifiable concern about the commercial determinants of health. There was a huge series in the Lancet that I think had some very high quality assessments. And these are all the systems and practices and pathways through which commercial actors drive health inequity. And I think there's some very hard-hitting comments there about the nature of these pathological systems in which commercial actors are increasingly enabled to cause harm and externalize the costs of doing so. So we work a bit with Health Coalition Aotearoa, which I think is doing some great work looking at these commercial drivers, the role of lobbyists, for instance. And even though New Zealand is rated as having very high transparency, there are opportunities to do better. And one of the things that and this is really this theme about long-term thinking, and this is reframing our horizon about who we should be focusing on. And I guess it's partly related to child health, the health of future generations. And one theme is feeding into preventing catastrophic risks. And of course, this has a political dimension. This was, I think Emerson is, I've really appreciated his cartoons throughout the pandemic and before that. And this was one example. And this is a well-known political figure you can probably recognize, saying, so a dictatorship of the unelected academics is still running what remains of the government's COVID policy. Mark my words, life would be very different if we had our hands on the helm. And of course, you can see the setting in which this politician has been placed. So I think, I hope I've just reminded you about why health communication matters for advancing public health. At one level, we're trying to create well-informed decision makers, practitioners, and the public, or nurture them, since many of them are already created that way. Providing some protection from disinformation, really supporting the public sector infrastructure, because we need that for strategic leadership and delivering interventions and so on. But fundamentally, I think it's looking at these determinants of health, including the commercial determinants, and strengthening our institutions and processes so that they are really promoted, those views. And one thing I would say is, if any of you are interested, please consider signing on to get on the mailing list, or even contributing to the briefing. We'd love to get your ideas. Thank you.
Mihi, Michael, and thank you very much for participating, and definitely looking forward to the work that's coming out of the Communication Centre. I think it's a pretty good initiative, considering that probably never before in a history have we ever faced such a difficult time with disinformation, and particularly it's important for us to build a new health system and build that trust up to a sustainable level. So thank you very much again. We now go to some questions, if you've got some time to hang around, Michael. And I see Barry's got his real hand up instead of his virtual hand. So Barry, go for it.
Thank you, Michael, for an excellent presentation, and also for the great work you did over the COVID. As you said, you became a very, well, some of us have known you for a long time, but you became a more familiar face to many more people than the few in the public health. I mean, one of the things that's really impressed me about your work is the ability to move beyond, if you like, the academic part, which is the fundamental of what we do, but actually into how do you communicate it. And I think a lesson, and one of the things that PHONZ is actually about, is the intelligence part. Intelligence is not just interpreting results, but actually communicating it and disseminating it. And I think for too long, academics have probably stopped the interpretation and said, well, it's in a scientific journal and therefore it works and it's fine. And I think that's one of the lessons that you've both experienced and brought forward, is this translating that into some action for people to take on board. So yeah, well done and thank you. And I think that's an important point that you've raised.
Yeah, thanks, Barry.
So just monitoring the Q&A chat boxes. I think we've got one question here from Wendy. Your advocacy during COVID was amazing, and thank you for that. In what ways did you personally feel supported as the communicator during that time?
Yeah, it is being interesting being in a university setting versus what I'd say is a more corporate environment, because universities are not really, most of the time you're kind of on your own from the institutional perspective, but you have a lot of supportive colleagues around you. I think that's the main support. And also, in my case, my department did free me up from some more routine work, which was greatly appreciated. So that's the way universities seem to work in a more organic way like that. So I did feel from my colleagues a great deal of support. But yeah, in other respects, universities don't have a lot of communication resources. There's no one to screen your emails. It's often just you and the journalist, and you somehow finding the time to do the thinking and the research, because the easy part I found was talking to the media. The hard part is working out what to say and what will make a difference. And one thing I did notice was you have to adjust your level of certainty when you talk, because we're used to 95% plus certainty, to use a convention, but often you've got 80% certainty or maybe a bit less. And I think it's one reason why scientists start to get very uncomfortable talking about particularly fast-moving issues, because you can't have taken them through the whole publication peer review process. You have to work much more quickly from first principles and your own interpretation. So I think that's something that I would just say to everyone who's in this situation, that sometimes you do have to shift your level of certainty quite a bit, your comfort zone.
Yeah, thanks for that, Michael. It's a good answer, and you can't go back, can you, to take back your words that might have been out of context or out of date. Our next question is a very good question, a simple question, but a very good question. Who profits from disinformation?
It's not going to cut itself.
Yeah. I would say there are a whole lot of potential people. Is that the?
Yeah, I guess it's quite a deep question for a Friday, but yeah, who profits from disinformation? I guess no one really profits from disinformation, do they? But I imagine there are people out there that have personal gains by putting their own agenda out and using misinformation to drive their agendas.
Yeah, well, I would say that there are a whole lot of potential ways that individuals and organizations and governments can profit in the sense. One is that quite a bit of disinformation has its origins in the natural food industries overseas, where by discrediting mainstream science thinking and vaccines, they are building the market for alternative therapies. I think most of the natural foods industry or natural products industry, I'm sure, is very respectable, but there are some that have seen a huge amount of increased traffic from basically providing negative views on mainstream medicine and vaccines and so on. So that's one commercial area. I think another is probably quite malevolent actors at a global level, basically funneling a lot of funds into organizations that will damage democracies. And I think that's a global issue. And that's what some of my reading has suggested. And then I think there are some fringe groups and some individuals who have essentially oppositional personalities, and for them, there's some personal gratification from opposing the mainstream. And some of them will coalesce into like-minded groups. And we saw that, I think, with the parliamentary occupation. You had, I think, the anti-vax movement is quite strong. It's got some very respectable international backers. It was a bit of a lightning rod, and a whole lot of other things coalesced around that, including people who decided it was a good idea to burn down 5G towers for some reason. So it was a strange mix of interests there.
Yeah, well said, thank you. Our next question, what is the best way to communicate when public health / medical scientists, who sometimes might self-designate themselves as such, are leading disinformation and manage to make their way to the mainstream medias or scientific communities? And they've got an example here of the French Marseille team. An example, hopefully that makes sense to you.
Yeah, I think all around the world, virtually every country has had its, I describe them as quite oppositional scientists who have taken a contrarian view and really stuck with it, despite evidence to the contrary. And we can think of, a few examples of in many countries. We had one example in New Zealand amongst the epidemiology community, the driver of Plan B, who devoted a large amount of time for more than a year to producing a website and putting a great deal of content on it, and being an expert witness for anti-vax groups. And it was very hard to work out why this person would do it. And I talked to this person a few times and I'm still mystified. So I think it's just the nature of populations that you get, you always have a small percentage who take a different path. So the question was, how do you deal with that? Well, I think it is, it's extremely difficult. I mean, in the university system, there's a high tolerance for people having divergent views. It's possibly considered one of the strengths of universities, and that sometimes those divergent views will turn out to be right, of course. So there's a very high bar for taking action against rogue academics. I think the public service is probably very different in that regard.
Yeah, no, well said again. Thank you, Michael. That was the end of the questions. If there's any more, we've got a couple of minutes left, so feel free to just put them in. I did have one question for you, Michael, and that was what you're doing on your sabbatical with the Norwegian Centre.
Yeah, well, look, this was a project that was worked out pre-COVID, and it was really led by a group in Oslo who have a long-standing interest in more the wide sweep, the historical impact of pandemics, and so they got people from all around the world to contribute. And the Norwegian government has teams, 3 teams every year that go in and research different things. And so one of the teams they funded was one to look at pandemics, and then of course COVID came along and changed the agenda quite a bit. So I spent 3 months there, and you know, it's fascinating being in a different setting, working with different scientists. So, you know, it's very helpful, but more than anything, it's just remarkable to see a society which really has a whole lot of major public health principles that they're really working very hard on in a lot of areas like transport and so on. So that was quite an eye-opener. And since then, I've got a month of basically traveling around Europe and the UK, visiting people I've got to know during the pandemic and never met, and doing lots of talks at universities and other places. There's huge interest in the New Zealand response, and there's an appetite really to learn from the pandemic about doing things better next time. And one of the arguments we're promoting, and it was a paper I published in The Lancet at the start of the year, about let's make elimination the default strategy for future pandemics, because then we can either stamp them out at source, which is obviously ideal, or delay transmission for as long as possible to give countries a chance to get vaccines and other measures in place. It seems like a logical thing to do, but at this stage, there is no global leadership along those lines. And so that's an argument that I've been promoting and other people have been as well. So lots of really great discussions at various institutions.
Nice. Yeah, sounds quite an exciting time, and it's great that you're waving the flag for not just New Zealanders, but also potentially the health sector that worked so hard and the response. So thank you very much again, Michael. There's no, I just see a last minute question came in here. With hindsight, is there anything you would now do differently in relation to communication around the pandemic? That's from Deborah. Good question. Thank you.
Yeah, I think the idea of just a higher level of kindness in general, I think is still, I mean, I know it's a bit of a slogan, but I think it's really important to be, you know, understanding of the different circumstances. And I think one of the harshest measures of elimination is that you basically have to manage your border very intensely. And that, I think, really was very hard on people. And I think perhaps at the early stages, the response was, you know, quite firm, and people understood that. But I think really allowing more opportunities for people to be, say, with dying relatives and some of these other things, I think were really tough. So I think we could have had a more targeted approach. These were quite blunt tools. But one thing is quite clear is that New Zealand had less time under lockdown, or we'd say stay-at-home order, than virtually every country in the world. So people sometimes forget that elimination actually was very good for health, very good for civil liberties, and very good for the economy. And that's what the data are telling us, and the groups that are analysing that at the moment. So we always have to compare it with the alternative. The counterfactual is not no pandemic. It was the kind of response, a chaotic response in places like the UK, and there's a lot of grievances here about that. So I think it is important to look at, or choose your alternative scenarios very carefully.
Yep, no, thank you very much. I agree with you. And there's a comment in there around how the elimination strategy can also be pretty harsh. You And I agree with that as well. It's not nice for anyone. And Barry, you've got your hand up.
One of the questions that I think most of the country would value your opinion on is how much of the success of the pandemic was down to the two, apart from yourself and say Siouxsie, that actually regularly fronted the media. How much of it, I mean, a compassion and all that, but we've seen in other countries where the people that fronted it actually made a dog's breakfast of it. I mean, we can think of the UK, for example, which didn't do a great job. So I'd be interested in your opinion. I mean, this is closed, so don't worry about that.
Oh, yeah. Well, I think there's two parts to this. One is you have to have the right strategy and you have to deliver it. So you can be the best communicator in the world, you can build huge trust, but if the strategy isn't properly formulated, it doesn't matter. You've got to have both elements. And I think New Zealand was fortunate in having both elements. We had the right strategy and we had effective communication, and the public service did a phenomenal job of delivering it. So that's right. I mean, I look at Sweden. They had a strategy, I think, was on herd immunity, which I think was the wrong one, but they delivered it they articulated it very well, and there was a lot of trust. And even now, the Swedes are saying they're very happy with the end result. So, you know, I think you need both elements. And some countries did both badly, and some countries probably had a good strategy but couldn't deliver it. So there's various permutations, but I think both elements were present in New Zealand, which was obviously fortunate.
Thank you.
Yes, no, there's definitely a lot of variables that could go wrong, but yeah, I think we definitely did pretty well, I think. Nice. Well, there's no more questions coming through, Michael, but if people do have questions, I'm sure we can email them to you, and you can answer them, and we can just put the answers on our website.
Right.
So on behalf of the committee here, thank you very much for your time, Michael.
Yeah, no, thanks, Tim, and thanks everyone else. Thanks, Barry.
Nice. That was a wonderful presentation. Thanks. And we'll move on to our next presentation. There's the wonderful Associate Professor Siouxsie Wiles. Siouxsie became another household name during the pandemic, and whose smile lighted up many families' lounges during the pandemic. Became the well-deserved Kiwi Bank's New Zealander of the Year for 2021. Siouxsie heads the Bioluminescence Superbug Lab at the University of Auckland and the search for new antibiotics, and has made a huge commitment to the effective communication of science, and this includes using art as a method to effectively communicate to the public. So welcome, Siouxsie. I now invite you to for your presentation.
Thank you so much. Thank you for the invitation to speak today. And it's great coming after Michael, because he's, I think, done a really fantastic job of introducing some of the things that I want to talk about today. So if you just give me a moment, I'll share my slides. Then, okay. So hopefully you can see this okay now.
I can see. Yep, that's good. Thank you.
Super. Let's slow that down. Okay, so I guess the way I've structured my talk is really to do it as a series of lessons, things that I've learned about science communication and the delivery of science communication during COVID-19. So my first lesson, to go. So actually lessons 1 and 2. So lessons 1 and 2 are basically to start early and to practice, practice, practice. And so I really, I guess I'm talking about this as a communicator, although I think it is exactly the same for communicating a topic. Is basically the earlier you start and the more practice you get, the better you'll be at it, and the better you'll be when you really need those skills or that communication to come to the fore. And so my journey as a science communicator actually started in 2005, nearly 20 years ago. So I was a research fellow at Imperial College London, and I was working on, well, part of my research involves laboratory animals. And I won the first ever National Centre for the Replacement, Refinement and Reduction of Animals 3 R's prize. And this is a pretty big deal in the UK. There was an event which was attended by the Science Minister. It's quite a big prize from GSK. And it was winning this prize and this organization saying to me that, you know, you have a responsibility to basically talk about your research, be open about your research, and then providing opportunities for that. So they started getting me into schools to talk about my work. There is nothing better, I think, than kind of getting your sea legs answering questions to children because they ask the most amazing questions. They're also really good at telling you when they don't understand something or when they're bored. So I think for me, it was really great training in learning to communicate, you know, with different audiences about my kind of academic research. So I started with this, you know, talking in schools. In 2009, I moved to New Zealand and started doing kind of public talks for things like the University of the Third Age and Rotary and those sorts of things. But I also started picking up a few other bits and pieces. So I started blogging for the Science Media Centre's Sciblog site. That kind of led on to becoming a science commentator for RNZ's 9 to Noon program. And then I also started, you know, YouTube was kind of becoming or just sort of coming to the fore at that stage. And so I started working with animators to make animations about science and bioluminescence, which is one of my passions. And through those animations, which we just put up on YouTube, ended up working with artists to make art exhibitions involving naturally glowing and harmless bacteria. So I was learning to communicate about science, my own science, through 9 to Noon, you know, lots of other people's science in lots of different ways, through writing, through speaking, and then through using these other means like animation and art exhibitions. And so that means that basically 10 years ago, I won my first set of prizes for science communication. So I won the New Zealand Association of Scientists Science Communication Award, I won the Prime Minister's Science Communication Award, and I won the Royal Society's Callaghan Medal, so 2013. So this is something that I have been doing for a very long time. And that meant that by, you know, kind of by this time, I had become somebody who had also, you know, knew how to speak to the media about things and had become a kind of go-to person when there were any microbiology related stories in the news. So I had covered, actually my big break had been this massive outbreak of food poisoning, E. coli in Germany in 2010. I covered the Fonterra botulism debacle, I think we can probably call it. I had covered Zika virus pandemic. I had covered the Ebola outbreak in West Africa. So I had been the person who had basically helped, you know, the media and people in New Zealand understand these stories when they've broken. And I'd also written a book about my main kind of area of research, which is antibiotic resistance. And so through that, had also been, you know, speaking to public groups and things about this particular kind of aspect of science and public health. So I was basically acknowledged as a finalist for New Zealander of the Year in 2018. So again, you know, another, this was all stuff that I was my bread and butter. And in 2019 was made a member of the New Zealand Order of Merit for services to microbiology and science communication. And the reason I tell you all this is not to brag, it's to show you that I had a long history of, you know, of really understanding, you know, like Michael said, like others have said, that our research doesn't end with a peer-reviewed publication. It ends with the communication of that research to whoever needs to understand it and know about it. And I had a long, you know, long done this. At times with very, well, it had been difficult, I think is probably all I'll say in terms of the support that I'd had from my employer. But what it did mean is that I felt like by the time the pandemic arrived, I had been training to run a marathon I didn't realize I was going to run. And for me, it really felt like the pandemic started just like all of those other things. You know, my phone rings, the media want me to explain this new story. And that's what I did. You know, those first interviews were just like, well, we don't really know what's going on here. And, you know, I guess it really just took a couple of weeks before it was like, okay, this is escalating quite fast. And I think it was, yeah, a few weeks before I realized this was going to be very different to how I'd, you know, stepped up in the past and what that was going to be like. So my third lesson then is basically the power of collaboration and teamwork. Because for me, I think what has really been extraordinary about what I've learned about communication during the pandemic has been not the stuff that I've done alone, but the stuff that I've done with Toby Morris. And so this really came about because so Toby Morris is a cartoonist who at that time was writing for the spin-off or drawing for the spin-off. I was very familiar with his work. He's done, you know, amazing cartoons about poverty and inequality. So he's someone I've long admired. And when I was writing for the spin-off, they asked me to write for them in kind of early January. They were like, if you've got anything you want to say, sort of pop it here. And I really like that because when you do media work, you might only have 2 minutes or 90 seconds to get your point across. And what I really wanted to do was be able to put all the things I was thinking and where I was looking at, you know, what evidence I was using. And so the spin-off kind of became that forum for me. But that all sort of changed when I saw this graphic in, so this would have been in February, late February 2020, which was basically a drawing explaining this idea of flattening the curve, that without protective measures, you know, the pandemic would kind of race through and we would soon overwhelm healthcare capacity. And, you know, we were starting to see that, to very much see that in places like Italy and China. Whereas if you put protective measures in place, you could hopefully, even if you couldn't stop cases, you could kind of reduce them. And you know, this idea of flattening the curve so that you could keep cases within your capacity to look after people. So I thought this was a really important message that people needed to understand, but that graphic to me was just awful. And so I immediately thought, I know somebody who could do a really good job of this. And so through my editor at the spin-off, Toby Manhire, I sent him a text to saying, you know, I want to do something about this. Do you think Toby Morris would be interested in working with me? And within an hour, we'd never met, but we were basically on a Zoom. I sent him the tweet. We had a chat. And then a few days later, we released our version of Flatten the Curve, where we'd put, you know, people into it. We'd sort of tried to make it much more much more understandable to a general audience, and really wanted people to kind of feel things. And so it sort of toggled between, it was a GIF that toggled between these two alternatives of, you know, overwhelming healthcare capacity or managing, not panicking, being careful, kind of managing our cases. One of the really important decisions that I pushed for really early on was to release this under a Creative Commons license. And so this is a license that basically gives people free rein to adapt, remix, translate, because I thought if this works, this is a message that is important, not just in New Zealand. And so we were giving people permission to basically take it and use it. It went absolutely doolally, that graphic. So, you know, within a few days, the Prime Minister was holding it up at a press conference, but it had actually gone all around the world. You know, BuzzFeed, the Huffington Post, kind of The Guardian, all sorts of people were starting to share it. And it sort of became, at that time, Flattening the Curve kind of became one of the really defining discussions on how we manage the pandemic. Like within about 5 minutes, I realized we've made a really big mistake and we should have been talking about elimination. So actually within days, we put out another graphic that was about elimination, but unfortunately that did not go viral to the same extent. and so, you know, Flatten the Curve became the thing that everyone was talking about. But, you know, almost immediately, Toby was like, right, what else can we do? And that really for us started this amazing collaboration where we've just recently written a paper about it. We made, now we've made about 70 graphics altogether, kind of covering everything from helping people understand what our measures in New Zealand were, you know, the concept of bubbles and our alert level system and things like that, right down to how do vaccines work, how does immunity work, you know, all sorts of things like that we've covered. Every one of them released under a Creative Commons license, every one of them with permission for others to use, remix and translate. And it's been amazing to see those things go around the world, to see which ones have picked up. Somebody on social media made a program that every time we released a new graphic, he would upload it to his program, and all you had to do is say what language you wanted it translated into, and then it would basically spit out a translation. So it was just amazing to see these things and how they moved around the world. And we had another one that went really viral, which was our trying to explain what transmission chains were and how you could basically stop a transmission chain, often by our own actions, things like getting tested. You know, when we released this, it was all about don't go to that barbecue or don't fly or work from home. And this one was actually taken and adapted by governments and organizations all around the world. And it was really interesting to see how they adapted it. Like, for example, and one of the examples here is the Australians who kind of changed the colors and things. We've got the Germans who made it really like straight lines compared to the curves that we'd used. And so that was a really interesting experience, seeing people take this and then, you know, use it again in their kind of public health messaging. Through all of this, the WHO, people at WHO kept being sent our graphics, and so they reached out to the spin-off, and Toby ended up working with them for a lot. I did for a little bit, but we basically adapted a lot of our graphics for a more international audience, where they were then shared on the WHO's pages and have had millions and millions of views. So yeah, so I think this work for me was kind of amazing because it brought my communication skills and my knowledge and my understanding of what people needed to understand with Toby's kind of visual communication skills. And it was a bit like it was better than the sum of its parts, I guess, or the two of us together had expertise, but bringing them together made something really special, and something that, you know, we've been told has been used all around the world in, you know, refugee camps, in doctors' surgeries, public buildings. You know, we get messages all the time from people saying, you know, your graphics saved my life, saved my parents' life, which is a kind of really amazing thing to experience, I guess. Okay, lesson 4. It's not just what you communicate, but how. This, I think, has been a really, it's something I've been learning intuitively over the years. But, you know, for many years, we've had this, this sort of deficit model of communication where people are empty vessels and you just sort of fill them with the facts and then they will do the right thing. And actually, that's not how people, it's not how people take information. It's certainly not how people decide whether information is trustworthy or not. And this is a lesson that's really well understood by those who spread disinformation. Like, they know that actually it's about the messenger, it's about how you deliver that information that's super important. And so for me, this really was about learning to not be the kind of expert figure as a, like, I'm a microbiologist and this is why you should, you know, believe me, but about how did I present myself and that information. And so really it was about being calm and transparent and accessible, to explain what we knew, but also what we didn't know. So to try to sort of bring in that uncertainty, to be practical and pragmatic. You know, that a lot of the things that would be great to do actually might have been really, you know, difficult. And so how did we sort of navigate that? But the other really, really important thing was about being myself, being my whole self, showing people what my values were. What were the things that I cared about? And so why was I saying the things that I was saying? And I think this is possibly the most important part about communication, because what we saw around the world is people take the same evidence and respond very differently, do very different things with that evidence. And so people would say, but, you know, why? Either they'd say, well, why didn't you do that? Like, what did they know that other people didn't know? Or, you know, why did you do something? And what we have to understand is, well, these are the things we care about. And if you understand what we care about, then you will understand why we might suggest doing different things with the same sort of evidence. So I think this was really, really important. And it really kind of, so I think it manifested in the way that I carried myself and communicated. But I've got a really, really good example of one particular piece of communication where I really felt this kind of be your whole self came in, worked really well. So this was when the vaccines started, you know, we were starting to talk about vaccines. And I started getting huge numbers of messages from people really worried about getting vaccinated. And this was especially people who were pregnant or trying to get pregnant or breastfeeding, really, really concerned about whether they should make this decision. I can tell you, as a woman who has been pregnant, you are bombarded with, information about things you should or shouldn't do. You worry constantly whether you're going to lose your baby and is it going to be your fault. And so I really understood where people were coming from. And so I wanted to write about what we knew at that time about COVID in pregnancy, but also what we knew about vaccination, which was very little. And so how do you convince somebody to do something, even if the evidence is not there, but you think that it's probably going to go, the way of you should vaccinate? And so what I ended up doing was writing a piece for the spin-off that basically talked about my journey to being a parent. I talked about having polycystic ovaries and my struggles getting pregnant. I talked about having a miscarriage. I talked about being an egg donor. So I wanted people to understand that I understood why they were concerned, that I'd had all of those same concerns myself, not about COVID and vaccination, but in general about being pregnant. In fact, one of the stories I talked about was that when my daughter was born, we lived in a part of London where the tuberculosis vaccine was offered to newborns. And so when my daughter was like 2 days old, the nurse came in, we'd like to offer you the BCG vaccine. And I freaked out. And what makes the story hilarious is that at the time I was a researcher working on tuberculosis and knew all about the BCG vaccine, right? I knew exactly what BCG stood for. I knew all the evidence and I knew all about, why they vaccinated newborns. And so if I could wobble, it was, why would other people not wobble, right? I worked through my wobble and my daughter was vaccinated, but talking about these things, being open about these things, being open about that uncertainty, but also why I thought people should do this, I think was really, really important. And I got so much amazing feedback from this piece where people shared it. And it was that being human and acknowledging people's anxieties and understanding and saying, I have these anxieties too, that really helped many people make the decision then to get vaccinated. So I think this bringing ourselves, being ourselves, telling people who we are and what we care about is really, really important, as important as the information that we're trying to talk about. Lesson 5, work with trusted voices. So this, I think, has been another really, really important lesson, and one that we, as communicators, as experts, need to pay more attention to. And that is that, so the research, certainly in things like vaccination hesitancy, really shows that, when people are hesitant about getting vaccinated, the people who can change their minds are the people who they love and trust, the people around them. They're not experts saying, here's the facts. They're people who connect with them on that personal level and say, I understand, and I'm somebody you trust, right? So what we have to understand as experts, as communicators, is that we will be the trusted voice for some people, but we will not be the trusted voice for everyone. And our job is to work with the trusted voices of whatever community we would like to, deal with an issue, so that they have the information, the right information, to be able to work within their communities. So for me, this took the form of an amazing relationship I made with this incredible woman called Tina Nata. She's an activist, a scholar, just an amazing lady who lives on the East Coast. And she's someone who their community have dealt with a lot of disinformation around 1080 and conservation sort of issues. And so she could see that if a vaccine came, her community could easily be influenced by disinformation, and she wanted to get in there first and basically do this kind of pre-inoculation, get everybody understanding, why vaccination was probably going to be a good idea and things like that. And so we built a relationship with her and her community, myself and Kate Hanna, who runs the Disinformation Project, Daisha Herbelock, who you've heard about, who runs the Science Media Centre. we and others were invited to the community. We went, we had a porphyry, we then did a community meeting, and we were there to talk, to them, to their trusted members, to their trusted voices, to talk about what we understood, what we knew, what we didn't know, so that the community could decide together how were they going to respond to COVID-19. And so it was just amazing what they decided after talking to us, was that they were going to be a community, an immunity community. So they were going to embrace vaccination, and they were going to do everything they could to get people in their community vaccinated. And what I found really amazing was, so we spent a couple of days up there, and as I say, we worked with their kind of trusted voices. One of the things we ended up doing, like we worked with the teachers from the local school. We ended up working with the children, because actually when we were there, the weather was really terrible. There were power outages, and so the school ended up being shut for the day. And so they all came to the marae and spent the day with us, because they knew that we were at the school, at the marae. And one of the things I ended up doing with the children was basically talking to them about kind of vaccines and things, and then asking them to think about, so if they were going to try to, talk to somebody they loved about COVID, about getting vaccinated, what would they say? How would they do it? And so we ended up with one group making TikTok videos. We ended up with another group making some posters. And one of the things they did was they decided to pick one person in their community that they would try and convince why they wanted them not to get COVID. And so one little girl said it was going to be her grandfather, because if her bicycle broke, who would fix her bicycle? It was all these kinds of things. So it was really interesting doing it in this way, right, of getting the community to talk about why it mattered to them that they looked after each other. So they did this amazing thing. They ended up making adverts that showed on television. They were absolutely an amazing community. They got hugely high vaccination levels, and they ended up being the New Zealand of the Year kind of community of the year in 2022. So it was just an amazing thing to watch, and disseminated their understanding, to other communities around New Zealand. Our job as experts was to be on hand. Like when new papers came out, we just said, there's this, or they would come back to us saying, we're hearing about this piece of research. Can you explain this? Our job was to help their leaders, their trusted voices, to understand, so they could talk about this at a community level. And I think this is an amazing model for how we should be communicating about everything, frankly. Okay. Last thing, and this is the kind of horrible stuff, and Michael has touched on this, is lesson number 6, which is prepare to be a target. So I'm a fat woman with pink hair who has spent a lot of time on the internet. So I kind of thought I knew what it felt like to be harassed, but nothing could have prepared me, I think, for what things have been like during COVID. So we know that this is a thing. So there's been several studies done looking at harassment of researchers. So one that was done by Nature that actually went through the science media centres and interviewed or got people who were communicating about COVID to fill out a survey. Another one, and this is the results of the science one, which basically actually did a brief survey of who was doing research or publishing papers on COVID, and then asked them to fill out a survey. So of those people who were researching COVID, basically 38% of them reported that they had been harassed. And I know this is a bit kind of busy, but these are all the different ways that people have been harassed. So things from personal insults and attacks on their credibility or capability, allegations of dishonesty and corruption, right down to, death threats, attacks on your home, attacks on your work, intimidation, stuff like that. So the ones in blue are these ones that I've backed are the only things on that list that I have not experienced. So I haven't had any suspicious physical mail. I've had nasty mail, but nothing that was suspicious. I haven't had anybody protesting outside of my home or work, although my home has been stickered by anti-vaccination people. So people know where I live. They share my home address, my contact details on extremist websites all the time. Like Michael, I'm on one of those lists of people who should be prosecuted and executed. these are just sort of like, there's a guy in Dunedin who's completely obsessed with me and doesn't think I have a PhD. So he sort of blogged ad nauseum about that. I get messages like this on my phone. This is a text about basically we're murderers, things like that. And as I say, I'm one of the people on this Nuremberg list, which is basically wants to have a trial and thinks that we should be executed for the work that we've done during the pandemic. So there's a lot of stuff that comes through social media. Actually, I don't see much of it nowadays because most of my social media accounts are locked down. So people will be saying horrendous things, but I actually don't see it. It's just happening out there. Before my account was locked down, people would just message me all the time with that. So it just became a really horrible place. So I sort of manage my social media so that I don't kind of have to see that, although I know it's kind of happening. And I guess one of the weird things is that you can now see all this because I happen to have been followed by a documentary maker since the beginning of the pandemic, which is the weirdest thing to kind of ever experience. And what happened was this lady was due to go to Japan to follow a Kiwi who was trained to be a sumo wrestler or something like that, right as the borders shut. And so she had money to make a mini documentary. She was looking for something to do because her documentary had just sort of vanished. And so she got in touch with me saying, I keep seeing you on my TV, can I follow you? And the only reason I said yes is because one of my best friends is an historian. And she said, you must document what's going on. And, you can ask Michael, we had no time to document anything. So I thought, oh, well, maybe just having her hang around for a few days, that will be kind of good documentation. And so she came and she spent a few days with me right before basically Jacinda announced that we were going into our stay-at-home orders. And she made an 8-minute documentary, which is basically just 8 minutes of my phone ringing. So if you want to know what life was like for Michael and I in those intense days, this will kind of show you just how intense that kind of media was. But she obviously couldn't get enough. And so she sort of said, can I just kind of follow you on and off for however long. And the great thing is that she lives in Wellington and I live in Auckland, so I didn't see her very often, but when I did, she just sort of documented things. And as the harassment and abuse that I've experienced kind of escalated, like she's just recorded all this. And so she's ended up making a film about it, a feature film, that is actually premiering on Sunday at the International Film Festival, New Zealand Film Festival. And so this will be people can now understand what it is that I have experienced through the pandemic and continue to experience. There's a little YouTube link down the bottom of there. If you're interested, there's basically, you can see the trailer, which is quite confronting. You'll see some of the stuff that people say about me. But yeah, I think it's important that people understand what it is that we actually go through when we step up and provide our expertise. And so with that, I think Michael did a really great job of talking about disinformation. The two things that I would recommend that you go and have a look at are the Fire and Fury documentary by Stuff, their Stuff Circuit team. And then Susie Ferguson from RNZ has just dropped her new podcast series, Undercurrents. So the first 2 episodes are out this week. The rest will come out, I think, next week and the week after. I think something people need to understand. This is basically for all of public health. This is now the kind of environment that we're working in. But I want to talk about a little bit beyond that kind of hatred, and this is how this sort of becoming a target for everybody. So Michael sort of, I guess, gave a little hint of this, but that I have become, and as Michael has, a target for the right wing. So I have been basically harassed by Judith Collins' office, national MPs, and Judith Collins herself, I guess, via Cam Slater. So people are looking for any evidence they can to discredit me, discredit Michael. It's just the most incredible thing, seeing people take stuff and basically mislead people. I guess create disinformation about us in order to further their own agenda. It's happened with people in the media. So Jason Walls, who's the deputy political editor at News Talk ZB, Heather Duplessis-Allen, these are people who basically take anything about us and try and use it to push their own agenda. The same with libertarian think tanks like the Free Speech Union and the Taxpayers Union. They are horrific. So it's not just anonymous people on the internet, it's really well-funded groups, people with big agendas and large followings. They can push this stuff too. But the thing that really knocked me for six this week basically came from a completely unexpected source, and it came mostly from the University of Otago. So I have a Google alert out for my name, which alerts me when any of these people are saying stuff about me. It helps me understand that there's probably going to be an uptick in harassment and abuse and threats. And so what I got notified of this week was a piece that's been published in Nature Medicine about nationalism, health nationalism. And what these authors have chosen to do is use basically a quote by me from an interview with the AM show in March 2020 as evidence of this nationalism in New Zealand. And it has been, I was just absolutely knocked over, actually, that I could be used in this way to push their particular agenda, that they didn't even think about the impact that this might have on me. Because this will have an impact on me. This will be picked up by these haters and they will use it again to try and damage my reputation. And the fact that they've done this in one of the leading journals in our field is actually quite appalling. So I only found out about this yesterday. I have contacted them and I wait to see what they say. But you become a target for everybody. Whoever has an agenda to push, whatever that agenda might be, and they can use you to push it, so they will do that. Michael was asked what support he'd had from his institution. I can say that I received no kindly taking me off of things so that I could spend my time on this. All I can say about the response of my institution is that it is subject to legal proceedings which began in September 2021. I was hoping it would end last year. We had a court date in September last year. That was postponed and we're now due in the court in November this year. I hope that it doesn't get postponed again. But once this becomes public, I guess people will see what the response has been by my institution. So my final thoughts are, clearly communication is something that we need to do. I think Michael has highlighted all the reasons why really well. My point is that we can't expect people to communicate their expertise and then leave them basically to fend for themselves when they will be targeted in the way that Michael and I have been targeted. And I guess, how can we as colleagues support each other? How can our institutions support us? Because this is just going to get worse and worse given the disinformation space is getting worse and worse. So with that, I will thank you so much for your attention, and I'm very happy to answer any questions if we have any time left. Thank you.
No, Mickey, thank you, Siouxsie. It was nice to hear about the story around where the animation for Flatten the Curve came from. It was very nice to hear, and yeah, it's quite alarming to hear how much sort of negative thoughts and comments have been thrown your way, and I'm sure Michael as well, but I think I can say that I think you guys are very brave, and I think you do have the support of the scientific community behind you. So I don't think you're alone in many of these battles, but you're unfortunately having to be the face that faces them. So thank you very much for that. We'll go to the floor for questions now. Anyone's got any questions, feel free to put them in the Q&A and also the chat. Maybe I'll start off with one, Siouxsie. Is there anything that you would do differently if you could rewind the clock and start all over again? Is there anything you would do differently?
Well, certainly maybe make the connection between not doing the flatten the curve and doing the elimination instead, like the fact that horse had already bolted. Literally there were like 5 days between us releasing the two things. So that's sort of my one big regret, was that that one didn't go kind of viral, I guess. I think my other big regret is not pushing kind of masking early enough, and like made the same mistakes many others made, you know, that like really worried about wouldn't have enough of the good quality masks, you know, that they would, that healthcare workers needed them and stuff. You know, that I think is my one of my big regrets. But I think that, I mean, a lot of the stuff, it's, yeah, what else? I think probably those are the main ones. I think a lot of where we are now is just, you know, to do with the kind of disinformation landscape. You know, I started talking about that quite early on, like trying to prepare people for this, you know, talking about the people who were profiting from it, how it was moving into New Zealand. Like that was one of the graphics that Toby and I did as well, where we adapted our transmission chain one to show actually, you know, information travels the same way. And so think about this, you know, what are the red flags when you see some information? So I think I wish we'd done more work in that space to prepare people for that. That's probably about it. I'm sure there are more if I reflected on it, but at the moment I'm just completely exhausted and a bit burnt out. So
Yeah, I can imagine.
I'm hoping I'll have time for reflection at some point.
Yes, it's quite the dilemma, isn't it? The what if, could have, should have situation. But a follow-up question, I would be absolutely fascinated to read about this. Do you have any intentions of writing down your experiences and perhaps a book in the near future of your experience?
I have had a couple of people approach me about that. I've started jotting some things down. I mean, I'm kind of interested in, I've sort of been thinking about doing it also just as a woman in science. Like I kind of view my career as a death by 1,000 paper cuts. You know, lots of the things that have happened to me, you know, like one of the really astonishing things, I actually thought that the pandemic would change, for example, my institution or my line managers, kind of how they value communication. As I say, you know, I've been doing this a long time and I've not been well supported. And so I sort of felt a bit vindicated that, like, you know, the pandemic hit and all this work that I'd done, there was finally they would go, oh, okay, no, it was worth doing all that stuff because that's actually been quite useful. But, you know, for example, we've recently had a pay review, performance pay review, you know, that covered 2020 to 2022. And all the work I did was not enough to get a performance-related pay rise. In fact, you know, I'm kind of being penalized now. Many of my colleagues have had a pay rise because they, you know, did the right things, and I obviously didn't do the right things. And so I think that I kind of want us to talk a bit more about that. And I'm sort of worried that if I open the floodgates to all the microaggressions that I've experienced through my career, it's not going to be a great book. Or maybe not good for my mental health. So yeah, I don't know. I'm mulling that over, or whether I could do something that was part memoir, part here's all the amazing things that I love about science, or, you know, about bioluminescence or something, so try and have something that wasn't quite so depressing. Because I really struggled. I got asked this week to write some words for you know, to encourage children to go into science, and I'm like, I actually feel so broken right now. I can't do it. I don't think this is a great career to go into. I'm worried about my career prospects. So yeah, it's kind of astonishing, I guess, to be in that position, to still feel after all that we've done, there's still really little care or consideration for us as people. Maybe it would be different if I was at a different institution, but yeah.
I think it's quite a common. I remember someone saying from Massey University in Palmerston North, he was an environmental scientist. I can't remember his name, but he became very prominent in speaking around water pollution. And Mike Joy, yes. His funding dramatically decreased, but his his interest in the public arena increased, which is quite a interesting correlation. Yeah.
I think you become known as communicators rather than researchers, and so despite the fact that what's astonishing I think about me is that I ended up being bought out for a little bit of the pandemic. It had no impact on me being bought out of teaching. I had to do all the same things. I actually, when I look at myself compared to my colleagues, I've been publishing the same amount. I've been doing all of those things the same while having this incredible service role. But nobody sees the other stuff. They just see the service role and they go, oh, well, you're obviously not performing as well as you could do in those other areas. And so it's just a weird place to be in. And I think it's just it might just be more about my environment versus others. But
well, yeah, I think you're definitely well appreciated within the public health and scientific arenas. So thank you very much, Siouxsie, and thank you very much for contributing towards the PHONZ conference today.
Thank you for having me.
If anyone's got any questions, well, there's a few here, but I think we're going to run out of time. So maybe we can send those to you, Siouxsie, and you can get back to us, and we can just put the answers on the website. Cool.
Thanks, everyone.
Thank you. Nice. I see Collin's joined us, who is our next speaker. Kia ora, Collin. Associate Professor Collin Tukuitonga is one of the most prominent Pacific figures in the health sector in Aotearoa and also internationally. Collin was a critical player during the pandemic, advocating for Pacifica communities and highlighting inequities within the Pacifica communities within the health sector. So Collin has held numerous high-profile roles, including Director General of Pacific Community, Commissioner and Coordinator of the WHO in Geneva, Director of Public Health at the Ministry of Health, and I'm sure I'm missing a few there as well, Collin. With that, I invite you to the conference, and you may go ahead with your presentation.
Well, thank you, Tim. Good morning, all. Kia ora tātou. I listened to most of your kōrero, Siouxsie, and all I can say is that kia kaha. I think that the work that you did, and Michael and others, of course, I think made a big difference, even with all of that stuff that you had to endure. So Tim, I might need some technical assistance here.
Sure. I think Patrick's online. He might be able to help as well. He's our behind the scenes IT wizard.
Not sure when. Oh, here it is. Yeah. So can you see that?
Yes, I can see your slides. And then if you just hit the full screen presentation.
Yeah. Just give me a sec. How's that?
Yep, I can still see your slides on the left-hand side. There should be a button down the bottom right, Patrick.
Yeah, which is
yes, that's right.
And it should say full screen mode.
Yeah. Is it?
You can continue just as it is, but we can see the main slide.
Sorry to cut in with the text board. What I can do is I can share Collin's slides from my computer and give him control of the slides as I play them.
That would be helpful, Patrick.
All right then, stand by a moment. And I will give you control. So you should see a notification asking you to take control of my screen.
Yep.
That should be all good. You can maybe have a play, Collin, see if you can move the slides over to the next one.
So Collin, you should see a notification. Oh yeah, there we go. I see you've got it. So now if you just click through the slides as you would normally, you should be able to control them. There we go.
Hey. Nice.
So thanks very much. Firstly, Barry, Kaaren and the team for inviting me. apologies for being tardy, but I am here, so thanks very much. My talk is on it obviously will take a perspective with regard to Pacific people. I find the title interesting, ethics, communication and implementation. And as I go through the presentation, be good for you to think about, we had a world-class response, is still my view overall, but I think we fell over when it came to the issue of the people most susceptible to the virus. And so the question I have for you is, was this a policy failure? Was it a communication failure? Was it an implementation problem? And what is the ethics of New Zealand as a nation protecting its most vulnerable? Did we do collectively what we should have done with respect to the most vulnerable? And I'm not speaking for Māori, I focus on Pacifica people, pretty much all of my current activities. Because in a way, this is not new. 1918, Māori had 6 times the mortality rate. The Te Loon that went to Samoa killed 22% of the population there. In other words, there's plenty here that we should have taken notice and acted on, and why didn't we? So I'm still, I have my own view, but I just find that the title is really interesting because I think it goes to the heart of my questions for all of us. Because the worst thing that could happen is that we repeat the same mistakes again. So that's really the background, if you like. I'm having trouble with this, guys.
It's all good. It is Friday, Colin.
Patrick, can you take the, are you able to?
Yeah, we get Patrick to maybe control the slides.
Go to the next slide. So so I'll talk pretty much about the Pacific community COVID-19 response, and the main thing in my mind is what did we learn? Did we learn anything, and are we going to apply it more effectively next time? I apologize to public health medicine colleagues because I'd already traumatized your eardrums with some of this previously, but I just think I feel strongly that we should learn from what took place so that we don't repeat it. But I do want to start, I'm old school. Some of you will have heard about Sandman and risk communication. So I just want to start with that by, next slide, Patrick, thanks. Talking first about communicating public health risk. And as I say, I'm a student of Sandman. Some of the discussion just now, I heard the tail end of Susie's presentation. Of course, I think the whole public health scenario globally and locally is getting increasingly complex. There's increasing public awareness, and everyone is an expert of sorts. There's distrust, I think, growing distrust of government, of science, of scientists, and certainly in the work that I did with colleagues at Auckland Regional Public Health, some of the difficulties we had liaising with and working with the churches. For the most part, the churches were helpful. But in some instances, they were distinctly unhelpful. So there is a level of distrust across all our communities. And of course, there's an element of people in the Pacific community that influences the rest of the communities, are the folk who are overstayers, and even though we said we're not immigration officials, and that they would be treated like everyone else in respect of contact tracing and so on, people were still pretty hesitant to come forward for some of the activities that we were engaged in. I think you will have heard already about growing misinformation, easy access to disinformation. I don't have anything nice to say about the New Zealand media right at the moment, to be honest. I think it's poor, appalling, biased, selective use of information. There are, of course, some very helpful media people that helped us to communicate the issues, but I think the media, and I don't apologize for this, my view is that we have a dreadful fourth estate, particularly in times of public health challenges like we've just had. And just to say, I was involved in the SARS. This might be ancient history to some of you, but at that time, we had the similar issues that were experienced again in the pandemic outbreak just gone. And this thing about voluntary and involuntary risk. So someone hops in a car tanked to their eyeballs and drives off drunk happily, but contacts me and abuses me for allowing these foreigners into the country and bringing SARS with them. In other words, they happily drive drunk, but are terrified and quite abusive with regard to a pretty low risk activity. And we had similar things with regard to the COVID-19 outbreak. People have a funny attitude to the pandemic, but still engage in highly risky behavior. And this is the point I make about voluntary risk. Oh, I'm good. I might be drunk, but I can still drive because I guess they figured that they can quantify that risk and they can manage that risk, quite diluted, obviously. But I think this has a bearing on some of the work that we do. Next. Thanks, Patrick. And so to go to my favorite person on risk communication, he talks about the risk is actually equal to the hazard, the quantifiable hazard plus public outrage. And he says that we make the big mistake of engaging with an unwilling and often difficult public about the quantum of the risk. Cell phone towers, for example, we go on and on and on about the fact that the risk is minuscule, but we forget the fact that actually for the public, they don't really care about the quantum of the risk. The issue they have is the outrage that this risk exists. And in fact, Sandman says, you're wasting your time trying to have a debate with people about the actual quantum of risk, and you're better to address and attend to their outrage and don't engage in a public debate. And he talks about the key factors in that relationship. Trust is a big one. And I know people in your sessions would have talked about the changing levels of trust in our country. Again, with transparency, he says it's important to respond early and to listen. Are the factors that are important in this engagement. Thanks. And so he talks about the three paradigms of risk. One is precautionary advocacy, early stages of a threat, where the hazard is high, but the public awareness and outrage is not quite there. And then the second is when, in fact, as the public outrage has escalated, and he talks about outrage management. Again, the point I made earlier about actually the risk might be low, but you got to attend to the outrage, public outrage. And of course, in a crisis situation, you're talking about both the risk being high and the public awareness and outrage being high. Next. So I've just put this up for you as an old one, the EPA 7 cardinal rules of risk communication: engage, involve the public, listen, be honest, frank and open. Be honest if you don't know, say you don't know. Coordinate and collaborate with other sources. Having trashed the media earlier, I note in the EPA rules that we should try to meet the needs of the media. And I guess that's true to the point. It's just that the way some of the information presented is not particularly helpful. Next. So to go to the pandemic itself, I still think, and I'm meeting the Royal Commission next week. This is my presentation to them. I think we had a world-class response. I think the failure for us as a nation is we didn't do enough or do well enough to address the issue of Māori and Pacifica people. And I still consider that the major failure for us, but overall I think we did well as a country. Second, I made mention already of the fact that we for some bizarre reason we didn't learn the lessons of history. I refer to 1918. Some of you will remember the meningococcal bee campaign, where we were fully engaged, and in fact the uptake of the vaccine for meningococcal B was high in Pacifica Māori communities, because we'd already had some prior experience, but somehow I don't know why, but we overlooked to use those lessons. It's not news to say that, of course, Māori and Pacifica people disproportionately affected in terms of the number of new cases, hospitalizations and deaths. And in fact, most of the deaths, as far as I can tell on the data, were in Pacifica people. In a way, this is a reflection of the chronic underlying inequities in housing, in income that exist in our country. And I will keep saying this because I think there's plenty of information to say that, in fact, the pandemic took place in a setting where there were already existing inequities in the determinants. Comorbidities, you would have heard about diabetes and so on, and I think there were clearly variation in access to and quality of care that was offered. Next. This is the Pacific response. I must say it took us a while to get going, but in the end, I thought we actually did well. When I say we, I mean the Pacific response as part of the contribution to the wider response. I chaired a ministerial Pacific clinicians mainly, and this is our main avenue for communicating with the authorizing environment, some public policy experts would say, meaning we presented the big issues from the community through the minister to cabinet, and as well as we were able to secure some resources to address some specific issues in the Pacific community. And I thought, as I say, it took us a while to get going, but once we got going with Pacific communities fully engaged with the Ministry for Pacific People, the Ministry of Health, organizing community meetings. Good God, I'd never done so many Zooms in my life. It just went on and on and on, but clearly a very important part, because when people were fully informed and were able to ask their questions, generally we got some good traction. Pacifica providers played a big part, not just in terms of public health and clinical issues, but in social support. The big issue for many of the Pacific families was access to food and social support. And there were, when you address those alongside your contact tracing requirements and so on, people were generally responsive. There were clearly a whole lot of other people involved. Next. So what did I think the success factors were? I think clearly Pacific community leaders engaged, owned the issue, and participated fully in the dissemination of information made a big difference. In some cases, it was slow and sluggish. Some churches were fantastic early responders, engaged their networks and got people fully informed. Some churches continued to hold church services when clearly we were in lockdown. I guess they believed in the divine power from up above to protect them. But you may recall that many of the cases in the Pacific communities, in fact, came through the churches. So I have a kind of a mixed view about that. But clearly the church as institutions are very important from a public health viewpoint. This one is for you, Barry. I think we slowly got improving quality of specific data. And I'm not talking about general Pacific data. We're talking about, you know, number of cases who are Samoan and so on. Over time it improved, but it was very difficult to get access to reliable specific data that we can act on. And I think it's still an issue, particularly for the observatory, to do better in terms of data that we need to mount an effective response. I think the availability of ethnic specific support, social support services and clinical services was important. In other words, not to replace conventional delivery, but to add to that, I thought was really important. I still think it was a slow start, but we had a good, I think a strong ending towards October, towards the end of the rollout. And as I say, overall, I think the churches were mostly supportive. Next. How did this happen? We've covered the slide. Next one. I think the in terms of the vaccination rollout, the thing that made the difference was communities owning the campaigns for vaccination. So this is, I think the Tongan Methodist Church in Whawona started the trend where they organized drive-ins through the church, and the first one, they vaccinated close to 1,000 people. Next. So this is, again, from that church. I think this was the event that was the turning point in terms of vaccination delivery for Pacific people. Next. Cook Island community had their sessions. Next. And next one. So the New Island. So just the next slide, Patrick, thanks. So clearly when we started to support communities to lead, to organize, it made a big difference. And I hope we don't forget those lessons if we will find ourselves in this situation again. Next. So I'll just finish off here by perhaps sharing some reflections. I think it's very important that we engage affected communities early. In the case of pandemic, not a COVID-19 pandemic, it was a struggle to, it should have been a natural part of our national response. But we had to advocate strongly. We had to try to get the system, if you like, to trust, to resource, to engage, and to allow Pacific providers and leaders to act. And so again, the point I'd make would be to empower and to resource people, communities most affected by the threat. It doesn't matter whether it's COVID-19 or whatever. That's a principle that seems to have been overlooked. Trust community leadership and actions involve Pacific providers alongside the colleagues that are also involved. I think we have to invest more in improving the quality of data across all our communities. You can't continue to expect better outcomes if you're relying on general data. And as New Zealand becomes more diversified, or there's more communities, there is a responsibility for us to have better data. You can't make good decisions on rubbish data, and that's a fairly basic principle. And the thing I keep saying is that I got some unwanted fan mail myself, but maybe I was naive. I just if I was feeling grumpy, I'd send them off some colorful responses. Most of the time, I just ignored it. But the point I want to make is that the Pacific response, and indeed the Māori response, is not a separate thing. Oh, sure, it's to benefit those communities, but it's actually for the benefit of all of New Zealand. Not much point in trying to manage an outbreak if there are parts of our community that are if you like, at a higher risk, and this is why I still think that we are indeed in one waka. And I don't think relying on conventional delivery works. We have to be much more imaginative. We have to engage the affected communities in respectful ways, and please do not ignore the lessons of history. Thank you, Tim.
Nami, thank you very much, Sir Collin. I can't stop thinking about the quote. I can't remember where it came from, but the one thing we learn from history is that we learn nothing from history. Thank you very much. It's nice to meet a fellow fan of Peter Sandman and his books, and can't recommend them enough to people out there. So it's nice to hear you talk about his work. We'll open the floor for questions. And feel free to use the Q&A and the chat function. Heaps of hand clapping reactions coming through there, Collin. Maybe I'll start with the generic question I asked Siouxsie, and what that was, if you could wind back the clock, other than what you've already mentioned by starting earlier with some of the interventions, what would you do differently?
I think I'd be much more vocal earlier. Start again. I would hope that the Royal Commission and related processes that we've been engaged in will help us to position ourselves for a more total and more effective and more inclusive response. You remember the Waitangi Tribunal report mid-pandemic. They said pretty much what I said. In other words, there were obvious things that we should have known or should have been aware of. In other words, I think, and I would hope that hopefully through the Royal Commission process, we come to a refreshed, updated, revised national response to public health threats, whatever they are, so that I don't, and my colleagues who take a particular interest in the case of Pacific communities, don't have to kind of waste energy trying to get to the starting line, that it becomes an automatic and normal part of our national response. That's my hope, Tim. But if it didn't, what would I do differently? I'd be even more stroppy, to be honest. I try to be polite, but sometimes, you know, politeness doesn't get you anywhere, and you need to say it as it is. So on this occasion, I think the Ministry of Health was behind the 8 ball, and I know why some of that happens, because the focus is on the majority, but I guess the problem is that people don't realize that the risk is highest in some sections of our community. So what would I do different? I'd be more vocal, I'd be more visible if we were not in the place to commence an appropriate response for our country. That's what I would do. I also want to highlight again, particularly for you, Barry, the fact that we should be investing more in quality data. I think we dropped the ball. There was a very good public health intelligence function, Barry, when you were at the ministry. Somehow that fell over, and we're behind the 8 ball. So starting tomorrow, starting yesterday, I think we've really got to have a look at our data requirements and build on it. And I acknowledge that certainly colleagues at Auckland Regional Public Health, they produced some good data, but you know they were behind the 8 ball. They were scrambling, and we should be much more better prepared, better positioned with the data that we need to make good decisions. So they would be the kinds of things that I would be pushing, Tim.
Yep, well said. And as Barry said yesterday in his presentation, rubbish in, rubbish out when it comes to data quality. Barry, I believe you've got a question.
I see him nodding, so I guess he'll invite me back next year.
Oh, definitely.
Colin, one question I have is, we had a national program to start with. Do you think it took too long to actually implement a specific Maori and Pacific programs?
Yeah, that's what I just said.
Yeah.
I'm not faulting the fact that the ministry and related agencies needed to put a national response, no question. But I think it was not balanced. And so it took us a while to wind up the Pacific. And as I say, I'm not fully across the Māori response, but knowing Mike, and we work very closely with Rahuri. And in fact, we exchanged texts about what we're going to do next. So in other words, we were sluggish, slow to put an appropriate response as part of the total response, knowing what we already know, that Māori and Pacifica people were always going to be at a higher risk. In other words, we should have known, if you like, but I think Ashley will kill me for this, but we should have known, I guess is my view, because we've had plenty of experiences, and we should have had a Pacific response from day one as a total and integral part of the national response. So absolutely a national response was needed, but alongside that, and as an integral component of the national response, there should have been specific strategy or plans or provision to fully engage the communities most affected.
Yeah, no, I fully agree with you, Colin, and you had some good reactions from participants as well, agreeing with what you've said. So if there's no further questions, I'd like to thank you very much, Sir Colin, for participating. And you most definitely will be invited next year.
Thanks very much, Tim. Thanks, everyone.
Thanks, Colin. Well done.
Okay.
And with that, that comes to an end of my chairing, and I hand the baton over to Buffett.
Thanks, Tim. Tēnā koutou katoa I tēnei rā, ko David Thomas, tōko ingoa.
I'm one of the presenters, members of the PHONZ steering group, and it's a pleasure to chair this last session today. We'll be starting with a presentation from Lou Wickham and Kylie Mason before we have a short break, and then we'll have 2 further presentations followed by the wrap-up by the steering group to finish. What a wonderful day to spend your Friday afternoon. So it gives me great pleasure for this first session to introduce Lou Wickham and Kylie Mason, who will be talking about their study on social inequity and pollution in Aotearoa. Lou is a director and senior air quality specialist with Emission Impossible Limited, an air quality consultancy in Auckland. Lou has a background in chemical and materials engineering and environmental law, and has more than 25 years experience working on air quality issues. Kylie is a principal analyst in the Environmental Health Intelligence New Zealand team at Massey University, which is a Ministry of Health funded group that monitor the effects of the environment on the health of New Zealanders. Therefore, welcome to you both, and over to you guys.
Thank you. Can you hear me okay? Oh, good. Thank you. Tēnā koutou, tēnā tātou katoa. Kia ora e aku rangatira. Kia ora e aku hoa mahi, kia ora koutou katoa. No whakatania hau, ko Charlie Lou Wickham Tukuitonga, kei te noho nei aho ki Tamaki Makaurau, kei te Emission Impossible Limited ahau mahi ana, ko mātanga angi hauora hau. Kia ora, hello, my name is Lou Wickham. I'm an air quality specialist with Mission Impossible Limited in Auckland, and I'm very excited for the opportunity to give this joint presentation with Kylie on our research to you today, and I hope you find it as interesting as we did. And I'll hand over to Kylie.
Kia ora tātou.
Kia ora. Okay, so this is our study team. Jane Metcalf and I are with the Mission Impossible Limited, and Kylie is with Environmental Health Intelligence New Zealand. This is a presentation about a study that we are about to publish on the ESR website. We decided to have a deeper look into the findings of the health and air pollution in New Zealand study, and specifically to consider the findings through a social justice lens. So whilst the HAPPEN study has been published, these aspects of it are new. I'm going to talk a little bit about air quality in New Zealand, give you a bit of a heads up, and then I'll briefly cover what we did, and then we'll jump into the fun stuff, which is what we found. So a quick intro on air quality in New Zealand. Outdoor air pollution is all around us. We don't typically have much personal control over the amount of pollutants going into the air or the air quality in an area. And that means that we don't generally have any choice about the quality of the air we breathe. So in science speak, that's called involuntary exposure, because we don't get to choose it, it just happens. In New Zealand, there are 2 key air pollutants that we know can lead to serious adverse health impacts, and these are particulate matter less than 2.5 micrometers in diameter, PM2.5, and nitrogen dioxide. The reason we refer to the size of the particle is because of physics. The size of the particle determines how it is transported through the air, where it ends up in the human body, and this in turn determines what type of health effects it can have. PM2.5, also called fine particles, can not only be breathed into the lungs, they're so small that they can be transported across the upper alveoli and into the bloodstream. So in New Zealand, the primary human-made sources of PM2.5 are wood and coal fires in the home. These, they're relatively consistent levels of PM2.5 across airsheds. It's what we call a ubiquitous pollutant. And this is a great photo, courtesy of Greater Wellington, that shows how this low-level discharge spreads out across an area. And the low height of the discharge means that it does not disperse under those still inversion conditions and can build up to surprisingly high levels given our relatively low population and our low population density. So this is Masterton on a winter's day, and you can see how the mixing height isn't even getting to the height of the trees. It's very low. Nitrogen dioxide, or NO2, it's gas, and in New Zealand almost completely comes from vehicle emissions. So the concentrations are generally highest right next to those busy roads and highways. And as you get further away from the busy roads, the concentrations decline. So this means that where people live, or where they can afford to live, will play a part in their exposure. For example, if you live on a busy road, you're more likely to experience high levels of air pollution, particularly NO2. PM 2.5 levels tend to be higher in towns and cities where lots of wood and coal fires are used, and also where the air gets trapped through topography and still weather conditions during winter. So generally speaking, people living higher up a hill will have less exposure than those living in a valley or a basin. It's relevant at this point to consider the human rights aspect of air pollution exposure. It may surprise you to find out that this resolution on the screen was only adopted by the UN late last year. But as of October 2022, a healthy environment is a human right. It kind of being necessary to live and all. And as I always say, you can go for weeks without food, a few days without water, but only a few minutes without air. So surely air quality is the most important. On with our social justice lens into air pollution in Aotearoa. This is our research question. We set out to answer, does population exposure to air pollution and associated health impacts vary by socioeconomic deprivation in Aotearoa? Well, it was just over a year ago, in July 2022, that the Health and Air Pollution in New Zealand study, PHONZ, was published. In science speak, this was a retrospective cohort study of long-term exposure to air pollution in a low exposure setting. It found statistically significant positive associations between pollutants, mortality and morbidity. In plain speak, it was a national epidemiological study that calculated the risk of dying or going to hospital because of air pollution in New Zealand. And it's relevant that the air pollution was relatively low compared with other countries in the world. Now, Siouxsie Wiles has presented some great graphics, and we had our own graphics for the PHONZ study as well. We, not me personally. Kylie was on the team that helped publish this. And this graphic explains the findings of the PHONZ study. So the health effects attributed to PM 2.5 are in orange on the left-hand side, and those attributed to nitrogen dioxide are in blue on the right. And the findings were reported in the newspapers as being startling, and that was due to that high impact of NO2. This was estimated to result in around 2,000 deaths each year and more than 8,000 hospital admissions due to cardiovascular and respiratory disease. And this is the first time that we'd ever quantified it, the impacts of NO2, and it was higher than we thought it would be. But that's not to say that PM 2.5 doesn't do anything. This added another 1,300 cases of premature mortality and nearly 5,000 hospital admissions to the annual tally. So the study was for a base year of 2016, and all that underlying health incidence data, population data, and air pollution exposure data was for 2016. So speaking of the underlying data, importantly, the PHONZ study also published a national health effects model, which contains all that really valuable health incidence data matched by census area unit to long-term air pollution exposure concentrations. And this is the basis for what we use to investigate how long-term exposure and health effects vary by three things. First, we looked at, First, we looked at the results by DHB area, and they don't exist anymore, but back when we started the study, they did. And they're really useful because the model disaggregates all the data by each DHB region. So gone but not forgotten. And we kept this aspect of the study. The second thing we looked at was social deprivation. The New Zealand Deprivation Index, NZDEP 2013, combines census data relating to income, home ownership, employment, qualifications, family structure, housing, access to transport and communication. So it's a really all-encompassing approach to looking at deprivation. And it groups all the scores into small areas in deciles, where decile 1 represents the areas with the least deprived scores, and decile 10 the areas with the most deprived scores. So an area in decile 10, and that's actually the dark red spots on the graph, on the screen here, are those with the most deprived scores. And they indicate that the area is in the most deprived 10% areas of New Zealand. So it's important to note that the NZDEP 2013 estimates the relative socioeconomic deprivation of an area, and it does not directly relate to individuals. So this means that you cannot use it to look at changes in absolute deprivation over time, as 10% of areas will always be the most deprived relative to other areas in New Zealand. Third thing we looked at was exposure by ethnicity. And this utilised 2013 census data, as this was the only available data that matched our exposure and health incidence data by 2013 census area unit. So what did we find? Drum roll. Well, as with the findings for NO2 and HAPPINS, our study revealed something quite startling. This slide presents the 2016 population-weighted annual average concentrations of NO2, and that's in micrograms per metre cube on that y-axis going up and down on the left-hand side, by the NZ-DEP 2013 deciles on the x-axis, as compared with that WHO guideline in red of 10, and that's the annual average air quality guideline for NO2. So HAPPINS found that more than 70% of people live in areas that meet the WHO annual guideline. And this, you can see that it's evident here with all the little triangles below the red line. However, this graph is also showing that on average, people living in the most socioeconomically deprived areas, that's decile 10 on the right, were exposed to higher long-term concentrations of NO2 than those living in the least deprived areas. That's decile 1 on the left. So in fact, it's 34% higher, 8.7 versus 6.5. And not only that, it's a straight line correlation with R squared of 0.8. Now R squared is the measure of goodness of fit of the model. So if R squared is 0.8, it means that 80% of the variation in the output can be explained by the input variable. And in other words, this is a really good fit. So we found, on average, more socioeconomically deprived people have higher long-term exposure to nitrogen dioxide, which comes from cars. So that's pretty unfair. We found quite a different picture for long-term national population-weighted exposure to PM2.5. So the HAPPINS study estimated that in the year 2016, the majority of New Zealanders, in fact 81% of us, were exposed to annual levels above the WHO guideline for PM2.5. That's the 5, the red line in the middle of the graph. So this slide presents the same data as before, and it really what it's shown is that exposure does not vary significantly by socioeconomic deprivation. And you might be able to see that the R squared it's rubbish, it's only 0.1. So I'm not sure if it's something to be proud of, but we have very fair PM2.5 pollution with nearly everybody having the same exposure. It's just unfortunate, it's all above the WHO guideline. So that was the natural pitch. Now let's look at things at a regional level. And I'm sure it's not a surprise that we found exposure varies significantly around the country. And if you're like me, you'll be looking at where do I live and seeing how it works out. This is the table of the 2016 population-weighted annual average concentrations of NO2 and PM2.5 for each district health board area. And you need to be a bit careful in looking at this data because some district health boards are really wide geographic areas which can smooth that exposure representation. However, noting this, the table shows for NO2, that's green, Auckland, Counties Manukau, Waitemata and Canterbury District Health Boards have the highest population-weighted annual average concentrations. Hawke's Bay District Health Board area is also elevated. And these are all heavily urbanised areas with significant vehicle emissions. So, okay, that fits. And for PM2.5, that's in blue, what this table is showing, it's presented from north to south, and you can see how it gets more and more blue the further south it gets. And that's reflecting that influence of the more domestic heating the further south you go, because it's getting colder. So you can see that the Te Waipanami, the South Island District Health Board areas have the highest population-weighted annual average exposure to PM2.5. Although they're still actually, pretty high in Lakes, Tairāwhiti and Hawke's Bay. So Hawke's Bay's got a double whammy there. This slide presents the percentage of population in each DHB region living in areas where the annual NO2 exceeds the WHO guidelines. And you can see again that it's going up, isn't it, across the socioeconomic, sorry, no, I'm looking at the next slide. Sorry, it's just showing the differences, and it's showing how elevated NO2 population exposure varies significantly around the motu. And it also reveals a disparity inside some regions. So the majority of people in counties Manukau, 61%, and Auckland, 85%, live in areas exceeding the annual WHO guideline. But just over the bridge on Waitemata on the North Shore, you've got significantly less population. It's only 35% of people. And there's a similar disparity between Canterbury, where 60% of people are living in areas that exceed the WHO guideline, and South Canterbury, where there's nobody. In fact, the percentage of the population exposed to NO2 levels that exceeded the WHO guideline was 3 times higher in the most deprived areas, that's decile 10, compared with the least deprived areas, decile 1. And you can see that's that split by socioeconomic deprivation, NZ-DEP 2013. So just to clarify, some of this information is already available on the EHINZ dashboard, which I recommend have a look at if you haven't already. And you can drill down into health impacts by territorial authority. It's got very cool graphics. What we did that was new was to look at that exposure by DHB and by socioeconomic deprivation. And this, here it is. This is the detail that really got our attention because it shows very clearly that exposure varies significantly in socioeconomic deprivation. But what I've done, and because I just don't trust percentages, this is actual numbers of people on the x-axis or going across. And the one that really stands out is counties Manukau. So here we have doesn't show the WHO guideline. It's each district health board from north to south from the whole of the country, and the bars are colour coded with green being less deprived through to red being more deprived. So the one that really jumps out, that big red line, in fact there's another couple behind it, that's the disproportionately high number of people in counties Manukau DHB that are living in an NZ-DEP decile 10 area that are also exposed to annual levels of NO2 above the WHO guideline, and that's more than 120,000 people. So I really care about counties Manukau way more than anywhere else. And I'm going to hand over to Kylie now to talk about the next bit.
So when we looked at exposure by ethnic group, we found other disparities. This table presents the population-weighted annual average concentration for both nitrogen dioxide in the green and PM2.5 in the orange. It's for the year 2016 and it's given by ethnic group. So these results show that for nitrogen dioxide, there are higher annual average concentrations for Asian, the Pacific peoples, and the Mila ethnic groups, Mila being Middle Eastern, Latin American, and African. But for PM2.5, there's less disparities. It's pretty similar annual average concentrations for PM2.5 across all ethnic groups. And if we dig into that disparity in annual NO2 exposure or nitrogen dioxide exposure, we can see that for Asian, Pacific peoples and the Mila ethnic groups, they were more likely to be exposed to annual concentrations of nitrogen dioxide above the WHO guidelines. So about 49 to 58% of these population groups are living in these areas above the WHO guidelines. And that's compared with 26% of the New Zealand European population across New Zealand and 23% of the Māori population. And we hypothesized that these results might be reflecting the different urban-rural splits of these different ethnic groups. For example, it could be that a higher proportion of Māori live in rural areas, while other ethnic groups, such as Pacific peoples, might be living predominantly in large urban areas. So we decided to do a little case study and look at urban areas in more detail. So this table presents the population-weighted annual average concentration of nitrogen dioxide in 2016. We've got and it's by ethnic group again. So we've got the national results, which you've previously just seen. Then in the second column, we've got national urban results. So that's the urban areas across the whole of New Zealand. And then in the third column, we've got Auckland urban airshed. And so this table shows that all ethnic groups in urban Auckland have higher chronic nitrogen dioxide exposure compared with a national average. And this is expected as urban areas have higher concentrations of nitrogen dioxide since the roading network is one of the main sources, compared with rural areas which tend to act to reduce the national average. So it also shows that the disparities in different ethnic groups' chronic exposure to nitrogen dioxide actually reduces significantly when you only look at the Auckland region. So now we've got 5 slides. We've got a little case study of the Auckland urban area and some maps to go along with it. And I'd like to give a quick shout out to Patrick for creating most of these maps for us. Thank you. So chronic levels of nitrogen dioxide, as Lou pointed out, they vary spatially with distance from roads and motorways. And that's actually clearly visible when you plot the data spatially. So this left-hand map shows the road network for Auckland with the main roads shown. And the right-hand map shows annual nitrogen dioxide concentrations by census area unit for 2016. And in this map, exposure has been color-coded by quintiles of exposure, with the darker colors representing the higher population-weighted annual average concentrations of nitrogen dioxide. So what's readily apparent from the map on the right is that the spatial distribution of annual nitrogen dioxide levels actually reflects the heavily trafficked routes and also industrial locations. So this map of nitrogen dioxide, you're going to see it in the next 2 slides as well. So just keep it in mind. So in this slide, we're looking at ethnicity now. So again, on the right-hand side, you've got the annual nitrogen dioxide concentrations. Darker colors mean higher concentrations of NO2. The map on the left shows ethnic groups in 2018 by location in Auckland. So of note, you've got Māori in orange, you've got Pacific peoples in green, Asian population in blue, Mila population in yellow, and European population in purple. And when these maps are laid side by side, we think it also appears to show that Asian and Pacific peoples tend to be living in high nitrogen dioxide areas in urban Auckland. And now if we look at socioeconomic deprivation across Auckland urban areas, so again, the map on the left is nitrogen dioxide, and the map on the right is NZ 2013 by census area unit, with the darker colours representing more deprived areas. And so comparing these 2 figures shows actually the picture is quite mixed for Auckland. For example, in central Auckland and North Shore, they have relatively elevated annual nitrogen dioxide levels, but these areas tend to be relatively affluent. On the other hand, in the western and southern parts of Auckland, the high deprivation areas tend to be in areas with higher chronic nitrogen dioxide exposure. And now just 2 slides now to look at PM2.5 in Auckland. So you may recall that we saw a little disparity in the population-weighted annual average exposure to PM2.5 by NZ in loose slides before, either nationally or by DHB. And so this figure actually shows why. So on the left-hand side, we've got a map of population-weighted chronic exposure to PM2.5 in 2016 for each CAU in Auckland, and we've got NZ dep on the right-hand side. And we can see from this map that chronic levels of PM2.5 are pretty similar across the whole of the urban Auckland area, with pretty little disparity in exposure. This in turn reflects the assumptions in the HAPPENS model, which rely predominantly on ambient air quality monitoring data, whereas annual NO2 was estimated using modelling. And just to finish off our little Auckland case study, the map on the left now shows the census area units in Auckland that exceed the WHO air quality guideline in dark blue, and you can see it's pretty much the entire Auckland. So it shows, yeah, all urban areas in Auckland are exposed to annual levels of PM2.5 that can cause harm to health. So I guess you'd be forgiven for thinking that PM2.5 pollution is pretty egalitarian. Right, over to Lou again.
Thanks. So we found that there's a disparity in exposure to air pollution by NZ decile, but we were also interested into whether this flowed through to health impacts attributable to air pollution. And when we calculate adverse health effects due to air pollution in an area, there are 2 main factors that influence the results. The first is the concentration of the air pollutant. So with higher concentrations, you'll get a higher percentage of health outcomes that are attributable to the air pollution. But the second thing that's also important is the baseline health incidence data. So with a higher baseline number or deaths or hospitalisation, it means that the impact will be higher. And that's important context to keep in mind when looking into disparities in the next few slides, and particularly when considering the health impacts of air pollution. I'm going to try and explain some of the structural inequities. There are structural inequities in the underlying data, and we haven't corrected for some of them. So our exposure response functions that we use to estimate the health impacts do address confounding factors, including age, sex, ethnicity, income, education, smoking status, and ambient temperature for a New Zealand context. That's the Hales et al. 2021 paper, which all of HAPPENS is based on. However, we haven't corrected for these structural inequities, such as, in particular, age is the one that really springs to mind when you're looking at different ethnic populations, when we applied our social justice lens on top of the data. So we've called this preliminary analysis, as the findings may change if we ever figure out a way of doing that. So here's the underlying health incidence data in the HAPPENS model without any air pollution. And this is just showing the base case rates for the New Zealand population stratified by the NZDEP 2013 decile for the key health outcomes assessed in the HAPPENS model. And there are 4 of them, and I'll talk you through them. The first is mortality, that's the blue crosses. This is for all non-external cause mortality in adults over the age of 30 per 100,000 people. That's the y-axis on the left-hand side. The second one is cardiovascular hospital admissions, that's the orange triangles, and respiratory hospital admissions, that's the green squares. That's for all ages per 100,000 people. It's on the right-hand side. All the morbidity things on the right-hand side y-axis. And then the fourth one is asthma prevalence per child up to 18 years old, and that's the yellow dots up the top, which is quite high. So just to clarify, prevalence is the proportion of a population who have a specific characteristic in a given time period. Incidence is the number of new cases in a population at risk in a given time period. So those yellow dots are the prevalence of existing asthma in children. And what this is showing, it's clear that the base health incidence rates for these health outcomes are already higher in more deprived areas. So as a starting point, this is pretty depressing because it's already unfair, and it's showing that more socioeconomic deprived people already have worse health outcomes even before you consider anything else. So this is what we calculated. This slide presents the health impacts due to human-made nitrogen dioxide stratified by their NZDEP 2013 decile. And our modelling suggests that the underlying health inequities between different deciles on the previous slide are exacerbated by higher nitrogen dioxide concentrations in those higher deprivation areas. And we think you can see this in particularly in the respiratory data. So that's the green squares and the yellow dots. That's respiratory hospitalizations and asthma prevalence, because the slope kind of kicks up on the right hand side if you compare it with the previous one. This slide presents the health impacts due to human-made PM2.5 by the NZDEP 2013 deciles. And it shows that despite annual average PM2.5 concentrations being similar in all locations and all populations, we're seeing here that the populations living in the more deprived areas have increased adverse health outcomes. And we think this is largely because of that base health incidence rates being higher. And one thing I think that's important, in addition to the air pollution increasing inequities in those health impacts in these areas of higher deprivation, the number of people affected is also higher in more deprived areas.
So just to briefly summarise the findings from the health impacts. So when we're considering health impacts from higher levels of air pollution, we found that in the more deprived areas compared to the less deprived, decile 10 compared with decile 1, the rate of premature mortality associated with exposure to nitrogen dioxide and PM2.5 is twice as high. The rate of cardiovascular hospitalizations associated with exposure to nitrogen dioxide and PM2.5 was 1.7 times higher. We particularly saw impacts with the respiratory outcomes. So the rate of respiratory hospitalizations linked with NO2 exposure is 4 times higher for them in the most deprived areas, and for PM2.5 is 3 times higher than the most deprived areas. And we also saw these kinds of impacts with the asthma prevalence in children as well. So if we think about it, the overall conclusions, we found significant disparities in long-term population exposure to nitrogen dioxide around New Zealand. And in particular, we found that chronic population exposure to nitrogen dioxide is elevated in certain parts of New Zealand, particularly the Auckland area and Canterbury and Hawke's Bay DHBs. It's higher for some ethnic groups, particularly Asian, Pacific peoples and Mila ethnic group. And some of this is explained by the urban area effect, where these population groups tend to be living in urban areas and large urban areas such as Auckland, and also people living in more socioeconomically deprived areas. In contrast, we found that exposure to PM2.5 varies by district health board, but not so much by NZDEP or ethnicity. And these differences actually carried over into the estimates of health impacts that were attributable to air pollution. So we found that the health impacts from air pollution are much higher in more deprived areas. And that was due to, firstly, the higher baseline incidence rates for diseases, which reflects the underlying structural and health inequities in these areas, and also higher levels of air pollution. And so, as an aside, it's important to note that our preliminary analyses don't take account, as Lou said, of age structure and other factors. So these might change results.
Okay, so that's all very depressing. We found lots of significant disparities, but there's always an upside. What our findings mean, and this is if you flip it on its head, is that policy that targets air pollution improvements in those more deprived areas would deliver bigger health benefits, and especially policy that reduces motor vehicle emissions. So there's the upside. And I'm going to finish with a blatant plug for a better purpose in our national environmental legislation, because it's up for grabs right now. Currently, the RMO only seeks to promote sustainable management, but in Aotearoa, New Zealand, clean air is a taonga for Māori. Shouldn't we be striving to achieve this basic human right? Thank you very much for your time and attention. We very much appreciate it, and welcome any questions.
Thank you, Lou and Kylie. A very interesting presentation on a subject that potentially can affect anyone in this audience today. It's particularly striking looking at the county's Manukau data and also the correlation between nitrogen dioxide and NZDEP in Auckland. One question I have for you, you got onto policy towards the end, and my simple question would be, what kind of policy?
Ooh, straight in with the hard ones. I remember asking if there's a range of policies, obviously, and of course we're always big fans of public transport and alternatives. It needs to be all of them. Getting people out of cars, shifting cars to a fundamental shift to green energy would be my first gig. But there's one thing that I bang on about a lot, and there's one thing you could do for public health is get people on bicycles. And clearly that's not going to work for everyone. And right now, as a friend pointed out to me, we're at peak car, so it's the most dangerous time you could ever be on a bicycle, and I know because I'm on one in Auckland. I look really stupid. I have a little flag on my bicycle, one of those chopper ones, but I'm an alive stupid looking person. It's the only way to do it, otherwise everyone tries to knock me off my bike. Those are the sorts of things that make massive improvements, and I know that there have been some initiatives undertaken in parts of Counties Manukau that may or may not have been successful. So if you're going to be doing it, it's got to be designed carefully and obviously with people in mind, and you talk to them first, because there's also been other research that I've seen that shows that if people are working two jobs and they've got to drive all across Auckland to get to their two jobs, they haven't got time to be faffing around with public transport. So it's got to be, fit for purpose, etc. I'm preaching to the converted here, but really those are the sorts of holistic, practical, but sort of linked up sort of policies that I'm talking about. Everything from fundamental shift to green energy, but actually getting people out of cars and moving. Kylie, did you want to add to that?
That's all good.
Okay, thank you. I'm just going to the question. We've got one question here. Would a tax on emissions work?
Oh, I'd be straying outside my area of expertise. I've seen mixed research about the clean air zones and say some of the taxes. I'm personally not a fan. It depends on the tax. I think we've got it would be how you design it, and I really wouldn't want to hazard an answer, is because I might be getting it wrong. I'm very anti anything that taxes people who've already, especially who are already struggling. A luxury tax would be great. Like I think that's a really good example, because it's really they're the disproportionate polluters. But that's my green bent coming through. You're asking me to step outside my actual area of expertise, which is just air quality.
Okay, no worries. Thank you. I can't see any other questions. Oh yeah, there's just one that's caught me right at the end. Words matter. Hey, please don't say everyone tries to knock you off your bike. As a person who relies on car for physical reasons, I always get told off by driving.
True, and that's fair call. It's because they didn't see me. They weren't trying to knock me off. They genuinely didn't see me, and I'd be coming up the inside lane, and they'd cut in, and that's why the flag works, because I look like a dick, but they can see me now, so I'm safe. Thank you. I stand corrected.
Awesome. One other question we've got: how did you decide which disease cases related to NO2?
These were specified in the HAPPENS model. There were 4 specific health outcomes that were assessed, and we used the HAPPENS model, so they were already decided for us.
And they were based on epidemiological evidence with solid research and evidence behind them. Yeah.
Thank you. I think that's our time now. So again, on behalf of the steering group and everyone listening today, thank you very much for your very interesting presentation. I hope you have a good rest of the Friday. And now we shall take a short break. See you in about 15 minutes. Ka kite. Having read the description around this presentation, it increased my interest, as Heather will be talking about ethnicity coding and geocoding, as I'm sure it will interest you all. Professor Heather McLeod is an actuary by training and has worked on healthcare financing, health policy, and social security policy for 30 years and is originally from South Africa. She has consulted to the Ministry of Health, District Health Boards, Hospice New Zealand, the New Zealand Aged Care Association, and Te Whatuora on the impact of an aging population on healthcare at the end of life. Heather recently completed a master's in climate change science and policy, and increasingly works on climate change issues. Therefore, we welcome you, Heather, and over to you.
David, thank you very much indeed. It's a great pleasure to be here. Tēnā koutou katoa, ko Heather McLeod ho. It's interesting, we've been talking a lot at this conference about the higher level issues, assuming that we have the analysis done and then getting on to talk about the ethics and talk about the communication and the implementation. I'm going to take us back a couple of steps to the base of the model that Barry put up earlier, and to be talking about the just the material that we are using to make the decisions that we are then trying to implement. As you said, talking about dragons, using this analogy of what old map makers used to do in areas where they didn't know, and to put warnings out there for other seafarers that there was something unknown, something that we needed to look at. And so I'm speaking today on behalf of June Atkinson from University of Otago and myself. I'll be focusing on 3 areas: ethnicity, deprivation, and rurality. And it comes from some work that I've been doing for the last 6 months for Te Whatuora, updating the evidence base for palliative care in New Zealand. Was done for Joe Hathaway, and this comes from some work shared with them in March and April. When I use the Te Whatuora background, it's material that was shared with Te Whatuora, and they've shared it more widely. Where it's a single blank background, it's June Atkinson and I commenting on things. So let's start with the first example, equity by ethnicity. And it's one of the important areas that we're being asked to provide information on at the moment. And we quite surprisingly ended up with data that gave us an insight into 2 different definitions of ethnicity. So what this was, I was working with the mortality collection, the MORT data from the Ministry of Health and now Te Whatuora. It's the 4th time I've worked on this data set. And so as before, I wanted to see ethnicity 1, 2, and 3 as provided and the prioritized ethnicity that they held, that I knew they held in the record. When the data arrives, there are two things I always do with it. Always check that ethnicity 1, 2, and 3 gives the correct prioritized ethnicity for Māori, and that any mention of Māori across those 3 ethnicities must be equal to prioritized ethnicity. It's a small check. It's one of the things that I run on every data set that I ever have access to. What I received was not what I thought I'd asked for. I ended up getting ethnicity 1, 2, and 3 is held on the mortality records, but a junior researcher had pulled this out this time and had inadvertently given me prioritized ethnicity from the NHI record. And I'm going to take you through the journey of what we saw and then why it matters so much. So 2 rounds of getting the wrong ethnicity before we finally got the correct one. So running that test of whether the ethnicity 1, 2, and 3 then gives us the correct prioritized ethnicity, this is what happened. Got a graph here running from stillbirth and under 1s through to 100 plus. And this is the proportion of people in each age band that were Māori in the data. And there was a difference, and there shouldn't be. And so this was our first intimation that there was something wrong. It was also interesting that where the dark bars, what we should have seen as the Māori ethnicity, and the light bars were what we were given as prioritized ethnicity, that it had a particular distribution, which is not uncommon in this kind of work, where there's, at the younger ages, we tend to see this biggest gap, and in fact, usually for males as well. But this difference was an issue. So we went back and talked to the ministry about the problem with the ethnicity. When you look at what we were given, the prioritized ethnicity had a big number of records with unknown ethnicity, and this is quite unusual. Usually the mortality data has very little in the way of unknowns. And so my first reaction between this figure and the one that we were eventually given, which was that it's probably just the unknowns being resolved. So I initially wasn't too worried. I was also aware of this wonderful piece of research by Ricky Harris and a number of other researchers, including June Atkinson and Melissa McLeod, no relation, that they put out this really lovely paper in the New Zealand Medical Journal recently, where they were analysing different sources of ethnicity data in New Zealand. The part that was really interesting was where they did this work at an individual record level. So they were able to look at the individual level records for those in the Primary Health Organisation enrolment data set and the census and look at the difference. And they found that in that analysis, Māori were undercounted on the NHI by about 16%. I knew of that, and so it was, this underrepresentation actually is also pronounced for Māori men with variations by age. So I thought that's what we were looking at, but it turned out to be much more serious. It wasn't just a case of undercount. It's actually a case of identifying different people. Now, let me show you what we found. We found that 51,000 people were Māori in both sets of data. So that's the mortality definition and the NHI definition. In the mortality data, a further 8,500 people, 8,600 people were found to be Māori. But what's happening is that if you use NHI ethnicity, it fails to identify those 8,600 people. It finds a different 4,600 people as being Māori. Just let that sink in. Only 51,000 are Māori in both data sets. We then have a group of 8,600 people identified in the mortality data set as being Māori that aren't found at all in the NHI data. So let's have a look at that. Some examples of that. NHI sees 254 people as being Māori, but they're actually, in the mortality data, Cook Island people. So they would end up being Pacific. NHI identifies 96 people as being Māori, but in the mortality data, they're Samoan, again, Pacific. This is a very complex picture, and in fact, anyone who's interested in this issue, I'm happy to share the spreadsheet that you can look at more carefully. What we've effectively got, and I just want you to look at the broad colors going on here. Coming down is the ethnicity code provided in the mortality data, and going across is the code provided in the NHI data. The green is where these two things are equal. And so basically your eye should just be telling you that there are large groupings of people here who do not have the same ethnicity using the two definitions. In fact, if you look at it just for Māori here, using the NHI data, here's the 51,000 that are in both sets, but here's the 4,599 people who are identified as Māori in this data set, the NHI set. Running across are all these other people identified differently to give us a total of 59,000 in that set. A simpler way of looking at it, here's the 51,000 Māori in both sets, 59,000 in the NHI set, 55,000 here. But people are coming out of different groups to be part of this. If you look at it on this side here, 14.4% of people in the Māori set, and I regard the mortality set as being a better measure here, 14.4% of them were not identified. And it's really serious. You think of the Pacific set, nearly 11% were not identified. If you're working on MILA, Middle Eastern, Latin American, and African group, almost half of them were not identified using in the NHI data set. That's really serious for any of us doing work on trying to say, what are the disparities? And more importantly, are the things that we're doing making a difference? Does it matter in the data? Absolutely. Here I'm showing an example from this mortality data set. The first bar here is Māori in both data sets, then Māori just in the mortality set, then Māori just in the NHI set against the not Māori in both. Just look at this this part here in blue, which is the proportion of deaths from cancers. The one set of data tells us that the people added had lower cancer proportion of deaths from cancer than not Māori. The other set tells us it's higher. It's that stark, these two different groups being identified. So, put it all back together, actually it's a proportion, a small proportion of the overall records, but we're getting different answers depending on the way we look at this. So, this is what I said to the ministry at the time. These are large differences, and this problem is deeply concerning. I'm not the first researcher to look at this. I was just reminded of some material. This is from a document dated December 2010. And 3 papers published at the time about problems in ethnicity, and particularly Māori ethnicity. Donna Cormack and Melissa McLeod writing at the time about how to improve the quality. Here we are 13 years later, I'm still finding the same issues. it's not just a numerator problem, but we have a different issue, that the denominator is also not that it's not as secure under our feet as we think. Just a reminder to researchers on board today that Stats New Zealand have revised the Māori population, and they did this as part of Census 2018, when it was a census that was being checked by administrative data, and they realized that there had been an underestimate back to 2013 of about 40 to 50,000 Māori as published in the 2013 base. There'd also been an underestimate of the Pacific ethnic group by about between 10 and 20,000 in the 2013 base. And very importantly, they went on to revise some of the 2018 base figures, but not the 2013 base figures. So a very important document, if you haven't looked at the detail, are the decisions about what was changed and where it leads to. And does it make a difference? Hugely. And it explains a difference that we see. I work a lot with the projections into the future. The projections that we had using the old base are here in gray. The projections using the new base are in red. Huge differences between the numbers that we used to think we would see in future and the numbers that we do see. This is projections of deaths. So it's really important, you know, the dragons that we have here are in the numerator and in the denominator. June and I think that you need to be extraordinarily careful about the source of that ethnicity data. Have a look at that paper by Ricky Harris and co about the different sets and the different results they got from the different sets. For a lot of the time, people will be working with live people. I have the luxury of working with the death data a lot of the time, and I think that's the better ethnicity ultimately. It's been very carefully cleaned. But the NHI ethnicity will be what many people are working with for a whole range of reasons. If you do have the ability to pull different definitions through, really give the results from both or all that you are able to get hold of, because they are slightly different. I think more importantly, if you're using or reporting on papers that might have used the old base population, those populations are probably wrong. And we should be very, very careful about restating. I think we need to go back and restate a number of those results using the new base population so that we do know exactly what, or have a better estimate of what those disparities actually are. If you're going to be using projected figures, make sure that you're using versions after it was announced. And so update 2020, 21, or 2022, which is the current version that we've got, are the ones that have that in. There are new versions released every year. But it's really important to go back and read the Stats New Zealand material on that revision so that you know whether any studies you've done in the past might need to be restated with a new base population. So that's the one area. The other area that we were looking into was rurality, and this fabulous work that was done in the last few years by a group led by J.C. Whittaker up at Waikato, Geographical Classification for Health. Now, you know, I'm not going to show you results from our study so much, other than to say to you, it's been a really interesting thing to find the patterns in the data by this new urban-rural measure. There are definitely patterns, and this is place of death for those with cancer, place of death for other needs for palliative care. And there are very strong patterns that we can see as you get increasingly rural. it also provides a very useful way for Te Whataora to talk about changes that are needed. You can't change someone's ethnicity. It's sometimes really difficult to work with the things that underlie deprivation, but you can get in there and change how things are delivered in different parts of the country. And so it's a lever that is somewhat easier to pull when you want to act on any of the analysis. So let's just talk a little bit about what is in this and where the issue arises that we discovered when we were trying to communicate this and communicate the results of the study. So Jessie Whitehead and team who did this fabulous work, again published only last year, categories urban 1 and urban 2, and then 3 rural categories. And it's based on the size of areas, but also on drive times. And this is an image that Jessie shared at some stage. We're finding it very helpful. This is the number of deaths, or the proportion of deaths using that measure. And so if you think of the northern region, very often we think of it geographically and we think of the very large rural areas that there are in the northern region. But when you look at it by the proportion of deaths, we find that 82% of them are happening in urban areas. And you can explain that if you break down that northern region into its 4 sub-districts. You know, within Waitemata, Auckland itself, and counties Manukau, well over 90%, in fact, in the high 90s, deaths are occurring in that urban 1 area. It's really only Te Taitokoro where you've got these large rural areas, and about half the deaths are occurring in rural areas there. So this gives us ways that we can have conversations about models of care and differences between different regions that we would otherwise see in the analysis. So my next step in having found some differences and wanting to talk to stakeholders about this was to put some graphs, some maps together to show them what I was talking about. And that's when we started discovering an issue. So this is the map that I first did. We had received domicile information from the ministry on the mortality data. We had applied this GCH using their concordance table for domicile. And this is the picture we got. But it's much more complicated than that. And I'm going to show you now 3 different geographies and some of the differences that occur. So to simplify it for ourselves, this is just the sort of northeastern part of Te Manuataki region. I want you to focus on this Tairāwhiti area and just keep your eye to start with just on this dark green area, which is rural 3. Now, this is the shape you get if you use domicile. If you use SA2 areas, that's the shape. So it's got a little chunk here of less rural. And this is the shape if you use the SA1 table. Let's have a look at another one. Look, put your eye here on U2, which is this big area for domicile. It's this big area here around Gisborne and all the way up the coast and here. But if you look at the SA2 version of that, it's only got the sort of lower half. The top half is actually rural 1. And if you go to the SA1 version, that's the shape. It's a much tinier area. And so having done the analysis at this domicile level, if I'd then gone and said, we need to change things in this area, I would have been completely wrong. That's not urban area if you get down to this geography. And so we started actually having a look at this, and that's when I pulled June in. We'd been talking about the ethnicity problem, and she's worked on both the GCH and on NZ-DEP, and did some work on it. And she's got a whole lot of material, and so I'm going to give people her details at the end if you want to actually take this further. But if we tested what a mesh block or SA1 was assigned to in the different things. Again, one of these, this is the using the mesh block or SA1 version. Here's the domicile version running across the top. The green ones are again the ones where it's identical. The slightly pink ones here are where people have ended up in a different rurality when we use the different geography. And so it's not a huge proportion of the people if you look at the census as a whole. For GCH, 97.6% did have the same GCH group. But June was testing NZ-DEP at the same time and came up with only about half ended up in the same NZ-DEP quintile. I'll try and give you an understanding of that in a moment. So this is the picture here below for the same sort of analysis, but doing it on NZ-DEP and how people ended up in different places depending on the underlying geography you use. I mean, part of it for NZ-DEP, we think, is that NZ-DEP is actually, it's a scale. And part of the problem is that people sometimes apply and just use a single number. And then when they aggregate up to these larger and larger areas with a single number, they're missing the underlying distribution that is coming from that. Be that as it may, this is our advice after a lot of soul searching and thinking about this issue. You know, sometimes domicile is all that you're going to get in the data, particularly in the national collections. It's a ghastly geography to work with because it dates back to area units from 2013. It's very different to the sorts of data that we can get. The Stats New Zealand geographies of 2015 and onwards have used mesh blocks very differently. They go up to SA1s, SA2s. In the latest version for Census 2023, they go up to SA3s as well. And so we've got this complete disconnect in health between the geographies being used in the ministry collections and what's being used with all the other data that we'd like to bring to bear. And, you know, June's advice here is that the gold standard, both for GCH and for NZ-DEP, is to geocode to SA1 level. Both of those instruments were designed for SA1. And so if you can get mesh block in your data, geocode to mesh block, and then amalgamate to SA1 and apply the SA1 table. That gives you the best and the most consistent version. Avoid using the SA2 tables. They don't work particularly well for GCH or for NZ-DEP. And, you know, domicile, if you've got to use it, do, but for heaven's sake, we need to find a way to migrate health to the new geographies. I was interested in some of the things Ron King was saying yesterday around geographies and the problems about geocoding. But, you know, we've just got to fix this to a point where we've got something really good to use if we're going to be talking about this issue. Some of my final points, you know, there's rightly a strong focus at the moment on equity. I've talked about ethnicity, deprivation, and rurality. I haven't touched on the even more thorny issue of equity by disability. I think that one's an even harder nut to crack. But the data that is underpinning our analysis and the things that we're publishing is not always as solid as we might think. And I think, you know, the challenge that Sir Collin made this morning to Barry about the quality of data for Pacific people. The quality of the data here is just not good enough for some of the things that we're now trying to say, or the improvements that we're trying to measure. And so, yes, I'd like to add my voice to what Sir Collin was saying this morning, and to the sorts of things Barry was talking about. We've just got to concentrate on this base and getting some of those things right, so that when we do talk about improvements, or we do talk about new research, that we're actually working with the best possible versions of these things, and be very, very careful out there. Right.
Thank you, June. A very interesting presentation, echoing a lot of the messages that we've heard before. And I see Barry is waving at me, so I assume he has a question to ask. Off you go, Barry.
It's one of the advantages of being a host, but you don't have to have the graphic, you can just wave your hand. Heather, thank you very much for that, and it reinforces obviously the theme that folks in PHONZ and certainly the PHONZ team have been pushing for a long time. The tragedy, I think, for this is that what you've found is not new, which I think you can assess to. I can remember years ago being involved in a mortality, hospitalisation, ethnicity difference, and I don't know how it's done now, but certainly in those days, ethnicity was recorded on the death certificate, the will, whim of definition of the undertaker. So if you looked a bit brown, you were Maori. If you had a strange name, or your colleagues, people of whānau were actually predominantly Maori, you were actually, that's what you were. And I know that the work that Tony Blakely did kind of brought this to a surface when he matched the census stuff. The issue the challenge I have, Collin gave me a challenge. Fortunately, we moved on from that. But the issue has always been who's going to lead this, who's going to do it. I mean, I have an approach that if a person has collects some data, they have a responsibility to ensure its validity. And I mean, there's enough evidence around to suggest that as researchers, we take that, it's been published, it's been whatever. So if you were to wave a magic wand, we're talking about dragons and magic, who has to clean this up? Who has to ensure that the analysis that we carry out on bad data is still not as good as it could be, but policy is getting made on that. So who has the responsibility?
Barry, it's not an easy one. I thought about what I wanted to put up there as a conclusion, and I really wanted to throw the challenge back to Aka Whaiora at the moment in terms of fixing up the Māori ethnicity. And the good news, I was looking at some of Ricky Harris's latest material, and her and Melissa McLeod have just finished a piece of work for Te Aka Whaiora on again recommending what needs to happen to Māori ethnicity. And we were trying to talk to her about it, and it evidently is being cleaned up by Te Aka Whaiora to be published, so we don't have a copy of it at the moment. So, that's the good news. We have a body that is crucially concerned about that issue, and let's see what they have recommended and what they're going to come up with. The other side of it, I think, is, I'm really thrilled that you have set up the Public Health Observatory. One of the things I think is a problem in analysis is that we've decided that people have access to the base data as opposed to a set of already cleaned data or the best available data. I have always done a lot of work with big data warehouse stuff and places where you can get consistency. And I think we've lost the capability to have a shop that basically works with the data regularly and on an ongoing basis and makes a cleaned version available for people to use. People who know the history of the data, you only have to think about something like pharmaceutical data or laboratory data. You know, one of the reasons I work so closely with June is that she's got an intimate knowledge of when, in what years this stuff was a problem and what other things happened in the system that caused, that mean that that data is not that good to use. We've lost a lot of that base knowledge by the loss of groups like yours, and you know, when you and Martin Tobias and others were at the ministry. So you know, that's, I guess, my long-term wish is that there's back to a really strong analytical group. It's not about data people knowing about the data, it's about the people who interpret this, who know the data and know that we've got a clean version to use for this kind of analysis. Yeah, that would be my long-term wish.
Thank you, Heather. We've just got one online question. Ethnicity is a self-reported affiliation. Should we joyously accept the uncertainty in a person's life? Otherwise, we would need a Department of Ethnicity assignment telling people what they are.
You raised some really interesting questions. You will hear in my voice that I come from South Africa. I've lived through the ghastliness of trying to assign people to ethnicities. And I'm not, frankly, that comfortable about using ethnicity as anything. I think there are some other things that we might think about, you know, and the deprivation is one thing, some of the social determinants, other social determinants, I think are really important. I like the urban-rural classification as a way to begin to think about some of this data. I'm deeply uncomfortable. Ethnicity changes over time. Trying to micromanage and talk about whether we're making an impact. I think we can see some broad things, but trying to talk about degrees of improvement off of data that's shifting all the time, I don't think you can, frankly. And this experience with the mortality data recently, I'm a kind of Bayesian statistician by nature. I'm interested in the quality of where the data comes from. I don't particularly like confidence intervals at all. In fact, I'm interested in where the data comes from, how clean it is and how good it is to use for decision making. And this experience of the data has really reduced my confidence in what we are putting out in terms of ethnicity.
I think we all hear you there. I'm afraid we have to move on despite the interesting conversation. Once again, thank you, Heather, for your time and your very interesting presentation.
David, you're on mute.
Pardon me, I was on mute. Thank you, everyone. Thank you, Heather, again for the presentation and your time. Some interesting points raised there and some good kōrero around the topic. We now move on to the final presentation. This is a recorded presentation by Dr. Kaaren Mathias and Dr. Annabel Ahuriri-Driscoll from Te Kaupeka Oranga Faculty of Health, University of Canterbury. They will be talking about increasing equity in healthcare for children and what's working. Dr. Kaaren Mathias is a public health physician and researcher with a focus on participation, inclusion, equity and mental health in communities. She is a senior lecturer in the Faculty of Health, University of Canterbury. Dr. Annabel Ahuriri-Driscoll is a Māori academic and researcher whose specialization is Hauora Māori from a public health perspective. Her research career has spanned positions at the University of Otago, ESR, and the University of Canterbury, where she has been involved in a diverse range of research kaupapa focused on Māori development and advancement. And as I said, this is a recorded session. So Patrick, take it away.
Tēnā koutou katoa, kei te mihi ki a koutou. Ko Waio, ko Annabel Ahuriri-Driscoll tōku ingoa. He uri ahau no Ngāti Porou, Ngāti Raukawa me Ngāti Kahungunu hoki. He rangahau hauora Māori au I te whare wānanga o Waitaha.
Kia ora koutou. Ko Waio, ko Kaaren Mathias tōku ingoa. No Putararu, no Tamaki Makaurau ahu. Ko Ototahi, tōku kainga e Naianei. And I'm a public health physician and also a senior lecturer here at University of Canterbury.
So our focus on this presentation today is sharing some findings from a small-scale realist case study of service providers who are focused on delivering care to children, young people and their whānau. So why this focus? We recognise that there are significant inequities experienced by particular subgroups of tamariki and rangatahi. And we know that inequality is more important to children and youth wellbeing than, say, total household income, and that those inequalities in Aotearoa cost over $200 million annually. We also know that health and social services have a critical role to play in either perpetuating or minimising child and young people health inequity. But there's little known about how exactly services achieve some of their outcomes, which then limits our ability to scale up what's working well. So we wanted to know what things are working well currently in local service delivery to tamariki and rangatahi, and how is that occurring. And so our overarching aim was to examine the practices and processes, interventions and mechanisms that increase equitable access to care and health outcomes with 3 service providers. And so we worked with Purapura Whetū, Te Pua Waitanga, Ki o Tautahi Trust and Early Start. The methodology we used is that of realist evaluation, which seeks to address how, when, why and where an intervention works or not. The point of difference or added value of this methodology is thinking in more depth about the causal mechanisms that occur between intervention and outcome. And so it's particularly useful when the boundaries between contexts and phenomena are complex and or difficult to distinguish. So we gathered qualitative data primarily, guided by a preliminary theory of context, intervention mechanisms and outcomes. And we conducted 16 interviews overall across service leaders and governance, kaimahi, or those involved in delivering care directly to clients, as well as a number of clients, including young people, their carers, and also mothers. And so these qualitative data were supplemented with information about the organisations and their mahi. We undertook inductive analysis of the interview transcripts, looking at what was emerging from people's kōrero relating to context, so that in which a program operates, such as the socio-economic and political environment, organisational context, local history and culture. Also interventions, so what was being done by providers. Mechanisms, the reasoning and reactions of human agents to intervention. So what's happening between the intervention and the intermediate outcome. Intermediate outcomes and final outcomes we're also interested in, so those significant short-term and longer-term outcomes. So the purpose of a realist evaluation is also about testing and refining a program theory as much as it is about determining whether and how the program worked in a particular setting. And so the program theory describes how the intervention is expected to lead to particular effects and in what conditions it should do so. And so here's the broad overview of how we understood the participating providers work to support young people in their whānau. So what they do and how they do it, giving rise to mechanisms or precursors of intermediate outcomes. And you can see the mechanisms here, or what we were thinking in preliminary terms, the changes occurring for the client that lead to those intermediate outcomes. And you'll see that there's still a significant amount of ground to cover between these intermediate outcomes and the ultimate outcomes of increased use of services and the associated health and social outcomes, reduction of inequity and so on. But also I think what this highlights is the relational core of these efforts to increase equity. And so that takes practitioner skill as well as an organisational investment environment that recognises the true, not instrumental value of those relationships. And so that's been the subject of some ongoing work that we've been doing. And what we found about each of the provider organisations is that they each operate with an equity lens, albeit with slightly different approaches. Pura Whitu, for example, is a kaupapa Māori organisation, has a focus on not only delivering to Māori, but delivering and extending kaupapa Māori to everybody, working with target populations, but including non-Māori whānau members also in need. Another feature was, the work being built on long-standing relationships and the notion of whānau staying with services for as long as they feel they need that connection. The services did well by being structured to meet contracted deliverables, but also being responsive and adaptive to whānau needs. And so this entailed providing what young people in whānau needed at a point in time, being able to flex in a pragmatic way, and also having a range of services or programs available. Organisations were also very collaborative with a view to maximising their coverage. And each of the organisations also sought to influence the structure and context of health service provision. They recognised that there was an educative component to their relationships with funders in order that there might be greater alignment between what's delivered according to whānau need and what is funded or contracted.
So we came up with 5 main hypotheses on how families were able to achieve outcomes and what were the mechanisms underlying. So the first one was about the value of the relationship, and particularly that when families were visited frequently and consistently, that provided a sense of safety, which then allowed them to talk openly and imagine their futures. And I really love this quote from a mother who talks about saying she was at the end of her tether and a kaimahi saying, you're going to get your big girl pants on, you're going to wipe those tears and you get into that lawyer's appointment. So there was a sense of belief and a sense of trust that there was that level of ability to engage and work together. And this was seen across all the organisations. So that aspect of relationship was really core. The second context mechanism outcome hypothesis was really about the value of lived experience, particularly kaimahi being able to talk about their life experiences in an appropriate boundaried way, but that gave a level of trust for whānau to believe that they could also imagine a future. And a really great example of this, we've got a couple of quotes here, but there was a young kaimahi, Sean, who was in his 20s. He had grown up in a very similar context to some of the young people he was working with, and he would typically meet them in a basketball court. And this young person here describes, because he's been through the same stuff, I'll ask him, how did you manage to make it through, manage to cope with whatever was happening? And so that seemed like a really important aspect of trust and hope ahead. A third hypothesis was that working in culturally embedded ways, which happened across all three of our case study organisations, was that it was particularly gave a sense of mana, of being valued, and also of capacity or agency. And this was really well illustrated in a program for young people, which was looking at giving them opportunities to give back in a tuakana teina program. And one of the young men described having been in some really difficult circumstances, being able to then help others, saying it makes me feel pretty cool that I helped someone do something. It always feels good helping someone, sort of leading that. And so that was a third key area for being able to engage and then work in other areas of sports and activity. A fourth one was around the idea of building skills, and we were particularly looking at parenting which was a skill building area across all three of the organisations we were focusing on. Some of it was I was there in an interview, and a Kaimahi said, "Oh, look at you, look at the way your baby loves you smiling. You're doing such a good job at telling that baby how much you love her." But also an example of doing the 5 languages of love, and one mother describing how that was really great, learned new thing, and that it had changed the way that it's saying it brought us and our kids closer. The fifth hypothesis that we're presenting here was around responsiveness, and this was really noticeable, the ability and the insistence by the provider organisations to say we have to be able to respond to the sort of social determinants of health. And so, you know, some of the time it was kai boxes or getting clothes or documentation for provider organisations. But this example here, one kaimahi described how there was a young woman who really needed to get her blood tests done, but what she was interested in was getting her driver's license. And she said, well, first of all, we got the driver's license sorted, and then she got herself to the blood test. And so that was really a long-term solution. So we presented 5 contexts and mechanisms that we believe led to outcomes. And obviously they're quite entangled. And I guess one thing with critical realist approaches is it's trying to find ways and mechanisms, but we acknowledge that a lot of these contexts and mechanisms are kind of crossover and entangled with each other. We haven't presented a big final program theory here because it's all still quite tangled, but we do believe that these mechanisms, which we sort of summarize here, are really critical for high quality services that are reducing inequalities. So trusting long-term relationships, the value of lived experience and service delivery, mana enhancing care, responsive approaches that engage with health determinants, and building new skills. So just to wrap up, there are clearly some really important implications for services, but 4 that we could immediately notice was that high quality relationships were underpinning all the other mechanisms we identified, that service contracts are going to lead to better outcomes when they're long-term, meaning, you know, 4 or 5 years at a minimum, it seemed like in these instances. That lived experience is really valuable and needs to be recognised and built into services, and that contracts need to be able to be iteratively developed, responsive and agile. So that's some of our learnings in this study. We've really enjoyed it, and we realise there's lots more to learn, but we're sticking around to be online now. So any pātai are really welcome. Kia ora.
Kia ora.
Thank you to Kaaren and Annabel for such a positive presentation, something really great to finish off this conference. And despite their comment there around being around for questions, they have been unable to make it this afternoon. So therefore, if you do have any queries or questions, please put them in now, and we will endeavour to forward them on to Annabel and Kaaren to get them answered for you. As I said, that concludes all the presentations, and we thank you all for attending and supporting this conference. And leaves me to hand you back over to our chair, Barry, to conduct the wrap-up. Kia ora.
Thank you, David, and to everybody that's still with us. We are delighted with the response that we've had from so many people this year. One of the things that we look forward to is your participation for the future. If you have any ideas for topics and themes, we're certainly grateful for those. Unfortunately, the steering group will probably say, oh, not already, but we'll have to start thinking about next year. But any help that you can give us. I think we've, the themes that we picked this year were highly topical. They talk about ethics, should be front and centre of everything that we do. And I think the early contributions for that were amazing and focused our attention. I think that the second day where we had that wonderful overview from John on the situation of public health or health intelligence in the UK and how much they have progressed, I think is a benchmark for us to try and aspire to. And one of the things I should do a plug for PHONZ is we're actually trying to follow along in their footsteps. New Zealand always follows what the UK does. That's why we have so many restructurings. But and we don't learn from their mistakes, so we just keep doing them. But that's another issue. But I think that the importance there is that John said is that we have to make this health intelligence a career path for people. And as we acknowledge that there is no training, even no universities do it. They do Massey does a thing of analytics, but it's more about crunching numbers, but not about asking the so what questions of what it is. And I think that's come forward very much in Heather's discussion, and also the discussions about communications. You can only communicate if in fact you've got high quality analysis and you can interpret it. So I think those three topics that we picked this year were absolutely great for the space, but we would welcome any further topics that you have. I'd also like to take the opportunity to thank all the members of the steering group. I think I'll say probably now it's been a lot of fun, but it's also a lot of hard work, but thankful for the chairman. And also like to the unseen person is Patrick, who actually keeps the machinery oiled and does a fantastic job. Doesn't appear much on the screen, but he's there doing a wonderful job. So I've got nothing else to say. Really that if the steering group people can stay on for a couple of minutes after, and I think Peter, you're doing the karakia at the end, but on behalf of the steering group, PHONZ steering group, thank you very much. We look forward to next year. We'll have a conference again, but we'll also, more importantly, for public health people, we will be holding a training course based on the UK one, which Chris Skelly does a lot of teaching for, and John has supplied a lot of materials. So that's something to look forward to. In the absence of any institution doing it, PHONZ is going to do it instead. So we are committed to a training course next year, the start of it, and also the 2024 conference. So on behalf of the steering group, thank you for everybody that's attended, and we look forward to your participation in the future. Peter.
Kia ora Barry, ngā mihi kia koutou rangatira māku tō mai ki tēnei hui o tātou, ka karakia tātou. Kia tātou katoa, te ata whao te tātou āre ki o hei karaiti, me te aroa ātua me te whiwhinga taitanga, me te wairua tapu, ake, āmene. Kia ora.
Well, thank you, Peter, and thank you, everyone. You can all sign off and go and have lunch, tea, wine, beer, whatever it is you fancy for the rest of the afternoon. But if the steering group folks can just stay for a little bit longer, that'll be good.